നാരായണ ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ് നാരായൺ, കേൾക്കുന്നുണ്ടോ?
സന്തോഷിനെ കേൾക്കാം. നാരായൺജി
ഗുഡ് ഈവനിങ് പറഞ്ഞത് കേൾക്കുന്നുണ്ടോന്ന് ചോദിച്ചത്.
ഞാനത് സെറ്റപ്പാക്കി വരുന്നു.
ഓക്കെ ഓക്കെ ഓക്കെ.
മറ്റേ 2 മീറ്റിംഗ് ഉണ്ട്, തൃശ്ശൂരും ഉണ്ട് ഇതിന് സമയം. തൃശ്ശൂരും ഉണ്ട്. അപ്പൊ ഗുഡ് ഈവനിങ് നായക്, സന്തോഷ്.
ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് സർ.
സന്തോഷിന്റെ ഗാർഡൻ ഭയങ്കരമാണല്ലോ. ഭയങ്കര പൂന്തോട്ടാണല്ലോ.
അതെ അതെ. എന്താ പറയണ്ടേ, ബാക്ക്ഗ്രൗണ്ട് ചേഞ്ച് ചെയ്യാലോ ഏത് വേണമെങ്കിലും.
അതെ അതെ അതെ, ഇത് നന്നായിട്ട് കുറച്ച്
അങ്ങനെ ഒരു പൂക്കൾ വെച്ചാൽ അത് കാണുമ്പോ മനസ്സിനൊരു സന്തോഷം
വരുന്നുണ്ട്.
സന്തോഷ് ജി ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ്. ഗുഡ് ഈവനിങ്.
രാകേഷ് ജി ഗുഡ് ഈവനിങ്.
Sir, hello sir.
Yeah. Very nice.
സുൽഫി ഗുഡ് ഈവനിങ്.
Hello sir.
ഗുഡ് ഈവനിങ്.
Good evening. Good evening.
Good evening.
കന്നഡ വേണ്ടേ?
സുധാകർ sir. നമസ്കാരം. മ്യൂട്ട്.
Okay. Good evening and happy Deepavali എല്ലാവർക്കും.
Happy
ഈ
Deepavali.
ദീപാവലിയുടെ പ്രകാശത്തിലും ചൂടിലും കോവിഡ് ഒക്കെ ചത്തുപോട്ടെ എന്ന് നമുക്ക് പ്രാർത്ഥിക്കാം.
ഹാപ്പി ദീപാവലി. ഗുഡ് ഈവനിങ് സുധാകരൻ സർ.
അതെ.
ഓ പ്രസിഡന്റ് നമസ്കാരം.
അതെ സുധാകരൻ, പാത്രം കൊട്ടി പോകാത്തത് പടക്കം പൊട്ടിച്ച് പറഞ്ഞേക്കാനാ പരിപാടി.
ശരി. അല്ല ഇത് ഒരൊറ്റ ദിവസമേ ഉള്ളൂ.
ഈ ഇതോ വർക്ക്ഷോപ്പ് 3 ദിവസമായിരുന്നു. നോർത്ത് സോൺ അല്ല സോറി സൗത്ത് സോണും പിന്നെ മിഡ് സോണും കഴിഞ്ഞു. നമ്മള് ഇവിടെ നോർത്തേൺ ഡിസ്ട്രിക്ട്സ് മലപ്പുറം.
എനിക്ക് ഒരു നേരത്തെ ഇട്ട ഒരു പരിപാടി ഇടയിൽ ഉണ്ട് എന്ന് പറയാണ് ഞാൻ. അതാണ് യൂട്യൂബിൽ ഉണ്ടാവില്ലേ അല്ലേ?
ഇന്നത്തെ യൂട്യൂബിലുണ്ടാവും, കാലിക്കറ്റ് യൂട്യൂബിലുണ്ടാവും.
ശരി. ഞാൻ ഇടയ്ക്കൊന്ന് മുങ്ങും, കാരണം ഒരു റോട്ടറിയുടെ വേൾഡ് ഡയബറ്റീസ് ഡേനെ പറ്റിയിട്ട് ഒരു ചെറിയ ഇവിടെ ഉണ്ട്.
ഇന്ന് ഇതിപ്പോ ഡയബറ്റീസ് ഡേ, ദീപാവലി, ചിൽഡ്രൻസ് ഡേ
എല്ലാം ഒരുമിച്ചാ വന്നിരിക്കണേ.
അതെ. അത് നേരത്തെ ഞങ്ങൾ പ്ലാൻ ചെയ്തതാണ്. നമ്മുടെ ഇവിടുത്തെ പരിഹാരത്തെ ഡയറ്റീഷ്യനെ കൊണ്ട് ഡയബറ്റിക് കൺട്രോൾ ഫുഡ് വഴി ഭക്ഷണത്തിലൂടെ പ്രമേഹം നീങ്ങുന്നു പറഞ്ഞിട്ട് ഓൾറെഡി നമ്മൾ അവരെ പറഞ്ഞ് ചട്ടം കെട്ടി. അപ്പൊ യൂട്യൂബിൽ ഉണ്ടാവുമല്ലോ, ഞാൻ ഫോളോ ചെയ്തു.
യൂട്യൂബിലെ ഒരു പ്രോഗ്രാം കൂടെ വെക്കാം, കാരണം പല കാരണങ്ങൾ കൊണ്ട് മിസ്സായവർക്ക് വേണ്ടിട്ട്.
ആയിക്കോട്ടെ.
എന്തായാലും കാരണം നെക്സ്റ്റ് വീക്ക് അത് നേരത്തെ അറിയിക്കാം, ഒരു പ്രോഗ്രാം വെക്കാം.
ശരി.
എന്തായാലും പല കാര്യങ്ങൾ കൊണ്ട് മിസ്സായിട്ടുണ്ടാവും.
അതെ.
ഗുഡ് ഈവനിങ് നാരായണൻ. ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ് സാർ.
CK സർ നമസ്കാരം.
നമസ്കാരം സാറേ.
അങ്ങനെ പോകുന്നു.
കോഴിക്കോട് വരുന്നില്ല.
കോഴിക്കോട് എമർജൻസി PG എക്സാമിന് വന്നിരുന്നു.
ആണോ? അറിഞ്ഞില്ല.
അത് കുറച്ചായി സാർ. അത് ഐ തിങ്ക് അത് ജൂലൈ 30 എങ്ങനെയാണ്, ആ സമയത്താണ്, കൊറേ മുന്നേ.
ശരി.
PG എക്സാം ഒക്കെ നടത്തിയിരുന്നല്ലോ, അപ്പൊ ആ സമയത്ത്
പിന്നെ എല്ലാരും സുഖമായിരിക്കുന്നല്ലോ?
സുഖമായിരിക്കുന്നു
അല്ലേ? സുഖമായിരിക്കുന്നു.
അതെ. സാർ ഒരു മാരേജിന് വന്നില്ലേ കാലിക്കറ്റ് അളകാപുരിയിൽ ഒരു ഇതിന് വന്നില്ലേ? അവരും വൈഫും കുട്ടിയൊക്കെ. വർക്കറ്റ് ഹോം. ബാംഗ്ലൂരിൽ
അത് ശരി. എന്തേ താമസം ഉണ്ടോ അവരെ? ഇല്ലല്ല, ഇപ്പൊ തുടങ്ങൂലേ? ഇപ്പൊ തുടങ്ങൂല്ലേ?
അഷ്റഫിനെ കണ്ടല്ലോ അവിടെ
ദീപാവലി ആയതാണെന്ന് തോന്നുന്നു പ്രശ്നം. ദീപാവലി ഉണ്ട്, ഡയബറ്റിക് ഡേ ഉണ്ട്, ഇറങ്ങിയതാണല്ലേ. ഞാന് ഒരു മെസ്സേജും കൂടി ഇട്ടിട്ട് തുടങ്ങാം. നിഹാസ് ഉണ്ടോ? തുടങ്ങാം നിഹാസെ. നിഹാസ് തുടങ്ങിക്കോട്ടെ. ഇനി ആളുകളങ്ങ് ആയിക്കൊള്ളോ. നിഹാസ് തുടങ്ങിക്കോ.
ജയകുമാർ നമസ്കാരം.
നമസ്കാരം സാർ. സുഖം തന്നെ.
തുടങ്ങാം സാർ. നിഹാസെ തുടങ്ങിക്കോ. നിങ്ങൾ വെൽക്കം പറ.
Okay. Respected President Narayan sir, Ashraf sir, President IAP Kozhikode, all other seniors and my dear friends. Today we are conducting the North Zone Conference, North Zone TOT of PMLTBI for children and adolescents. So we are including this conference for Wayanad, Malappuram, Kozhikode, Kannur and Kasaragod districts. So I'm not taking much time. I like to welcome all our dignitaries who are going to take sessions today. Dr. Faisal, Professor HOD of MES Medical College, Dr. Ranjit P, pediatrician from Government Health Services, Dr. Mrudula Shankar, and Dr. Narayan Naik sir. I'd like to thank Dr. Narayan sir for this amazing program which has been conducted all over Kerala, and his under his presence action plan to train all the pediatricians on the changes in treatment and prophylaxis of TB, latent TB infection in children. I welcome Narayan sir to this meeting, our dear president. And I also welcome Dr. Rakesh, the WHO consultant, and Dr. Ashraf TP, the convener of Presidential Action Plan, IAP Kerala. I welcome all others who have joined us today for this session. We have almost 300 plus registrations today. I think slowly they'll be getting into the session. I request Dr. Narayanan to start with the proceedings and take over the sessions to the moderators.
Thank you, Dr. Nihas. Good evening to you all. Dr. Ashraf, who is the president of IAP Kozhikode as well as the convener for this program. Dr. Nihas, Dr. Vijay Kumar, Shashidharan sir, other senior pediatricians, and my dear colleagues. This program, it's a training program on tuberculosis, that too on latent TB infection. It has been there from the 1st of November when Honorable Governor inaugurated the program. It's one among the action plans of IAP Kerala for this year, that is TB-free air for every child in Kerala. That's our caption for the program. So we started the program way back in January 2020. Then we had some workshops. Then finally, after due to COVID and all, we did not progress much after that. Then we restarted the program with on the Kerala Piravi Day. See, the idea behind the program is to help the government and our country in their mission to end tuberculosis by the year 2025. Our share, the pediatrician's share of duty and responsibility in this regard is manifested in this program. Actually, Kerala is the first state to have a TB control program, a TB treatment program for latent tuberculosis, started this year. It's the first state to do that. We all know that latent tuberculosis, if properly treated, if the contacts are treated, the children with the positive contact history, if they are treated well, we can bring down the incidence of childhood tuberculosis disease to 10%. So there will be a drastic fall of 90% of the disease if we do the latent TB treatment. And the guidelines for this diagnosis and treatment program has been formulated by IAP with the help of State TB Cell. So we had nearly 4 sessions. The experts from IAP sat together, about I think 25 people were there, they sat together. Then we made a draft, which was circulated to all the medical colleges, teaching hospitals and senior consultants. We had their opinion, and finally it was presented to the central TB, the central TB officer, and they agreed to our proposal, and the program was launched on the 1st of November. And that day, there were representatives from WHO, Deputy Director for TB was there, from the Central Division was there, and the Governor inaugurated the program. There are certain changes in the diagnosis, our approach to latent TB, and the treatment part. Main thing is that instead of the INH prophylaxis, we are moving on to INH rifampicin combination prophylaxis. That's the main point in the program. And we have a faculty who will be going in detail on every aspect of diagnosis and treatment. So it will be easy for all of us to do. There must be uniformity among pediatricians in the diagnosis and management of LTB. And coming to the northern part of Kerala, the studies show that maximum anti-tuberculous drugs prescriptions are from the states of Malappuram and Kozhikode. Sorry, the districts of Malappuram and Kozhikode. It's a study shown by the state TB research officers. So maybe they are having more tuberculosis in that region, whatever it is. So this area deserves special attention and our focus in the eradication of TB. And to help the pediatricians, we have the module, then we have the module that will be familiar to all of you today. Then, if at all you have any doubt or difficulty in managing any childhood TB case, we are forming a district committee of 5 people in each district. So there will be a representative from TB cell, then 1 pediatrician from government sector, 1 from the private sector, and from the medical college section, and government service also. So that committee will help you to plan your treatment on TB. So it will be easy for pediatrician. So what we are going to have is a uniform protocol for latent TB. And if any doubt or help is required, we have a helpline for that. So that's a plan we are having. And this program of training pediatricians across Kerala, our target is to train 1,000 pediatricians. Roughly, there will be 1,000 practicing pediatricians in Kerala. Even maybe more than that. So out of our 2,500 members. So we had the zonal training in the south and mid zone, which was attended by 600 pediatricians. So the remaining 400 has to come from maybe some from north zone, and maybe some people have they could not attend the program. So we'll have a program today, and if at all, today being a Diwali day, then Children's Day, World Diabetic Day, so many programs are there, and weekend and Rotary programs, so many programs are there. If at all, if you are not able to attend the program, we'll have another mop-up program at the state levels where all can attend. In the Zoom meeting, at least 500 can enter, so there won't be an issue. So every pediatrician in Kerala will be having a training for this thing. And we have senior pediatricians and our teachers here. So if at all anything, any amendment or any clarification is required, that will be most welcome, and we will be able to incorporate that also into the program. So with that, I wish this program all success. And I should thank also Dr. Ashraf, who is the convener of the program. I should mention his name specially because he is the person who has been behind the drafting of the program, and he has been moderating the other sessions. In workshops, I mean, training programs in other two zones, spending a lot of time with us with a lot of enthusiasm, commitment. And other moderator is Dr. Rakesh. Actually, he is the person who suggested me this caption of easy TB-free air for every child in Kerala. It was Rakesh's idea. And the Central TB Division, the State TB Division, the WHO are all behind us, with us, not behind us, with us. So with their support, we will be able to achieve this mission, I am sure. And these few words, with your permission, I inaugurate this session and I hand over the mic for further procedures to the moderators, Dr. Ashraf and Dr. Rakesh. Thank you. Thank you.
Thank you. Thank you, Dr. Narayanan. First of all, let me congratulate our State President, Dr. Narayanan, for including this program under his Presidential Action Plan. And I also thank the State TB Chief, Dr. Sunil Kumar, WHO Consultant, Dr. Rakesh, Dr. Shibu, and many other experts in the Central and State TB Division for accepting our proposal regarding the programmatic management of the latent TB infection in children, which was arrived after several discussions and deliberations through multiple Zoom meetings. And now we will discuss in 4 sessions what is the programmatic management of latent TB infection in children. And there are subtle changes from the national guidelines. So my request is, this program is particularly about the management of latent TB infection in children. It is not about the management of TB or active tuberculosis in children. So your mindset may be adjusted to that. With these words, Dr. Rakesh, any introductory comments?
Nothing, sir. I think Dr. Sunil Kumar is there, so okay. we'll ask him to speak, okay. Speak a minute.
Okay. With these words, I invite Dr. Faisal. Faisal is the Professor of Pediatrics in MES Medical College, Perindalmanna, to discuss on the eligibility criteria, which all children, which all groups are eligible for latent TB management. Over to you, Dr. Faisal. Faisal, please unmute.
Thank you, sir. Good evening, everyone. Respected President Dr. Narayan sir, Convener Ashraf sir, my senior teachers, colleagues, and friends. So, today we are going to discuss about the eligibility criteria for latent tuberculosis infection. And 1 second. Am I audible?
You're audible, Faisal. Please.
And can you see the screen?
We can see the screen. Please go to your presentation, your PPT.
Okay, thank you, sir. So today we are going to discuss about this IAP along with NTEP has brought out this programmatic management of latent infection, which will be introduced in this month probably. And
so the PPT open
Kerala, you know.
A PowerPoint on open G.
Yeah.
It is not yet come.
It's not coming. Nice, this thing it is coming.
Sir, the share screen on not restart.
1 second. Not coming.
Sharing stop ചെയ്തിട്ട് വീണ്ടും റീഷെയർ ചെയ്യേ. നിങ്ങൾ ആ പ്രസന്റേഷൻ എടുത്ത് ഡെസ്ക്ടോപ്പിൽ ഇട്ടോ.
Okay.
PMLTB ഒക്ടോബർ 30 എന്നുള്ളതാണ്. ഏതാണ്?
Yeah, that it's coming.
ഇല്ല.
1 second.
Presentation മാത്രം ഓൺ ചെയ്ത് വെച്ചിട്ട് ബാക്കി എല്ലാ വിൻഡോസും ക്ലോസ് ചെയ്താൽ മതി. എന്നിട്ട് ഒന്നുകൂടെ ട്രൈ ചെയ്യും.
അതാണ് ഏറ്റവും എളുപ്പം. ഈ ഒരു പ്രസന്റേഷൻ എടുത്ത് ഡെസ്ക്ടോപ്പിൽ ഇടുക. എന്നിട്ട് ഈ ഫയലൊക്കെ ഒന്ന് ക്ലോസ് ചെയ്യുക.
How is it, sir?
Sir, share screen on not stop here. Stops. Okay, one.
Okay. Any
enable editing
slide show. Okay.
Yes.
Okay. Very good.
Okay. Thank you.
First slide to
So as you can see, yeah. So as you can see, Kerala has an excellent, social developmental, excellent record in social development, especially in health and education. And in Kerala, the growth rate is declining. There is a demographic change in growth in population. The aged population, people who are aged, proportion of people who are aged are increasing. And the infant mortality rate is around 7 per 1,000, which is way ahead of other states. And we have got a high literacy rate, especially female literacy, and a systematically organized primary healthcare system, and also a low HIV transmission, especially maternal to child transmission is also very much reduced. And this graph showing the estimated total TB cases in Kerala 2020 and as you can 1,000, and it has reduced to around 25,000 in 2020. And if this trend continues, we'll have around 10,000 cases in 2025. But our aim is to reduce the case to 0 by 2025. And overall view of pediatric TB in Kerala, the annual decline in pediatric TB notification is 7.5% each year from 2009 to 2019. And the age-specific TB notification in children less than 14 years is around 1 per 1 lakh population, which is also a very good indicator. And the kid formulation of TB drugs, the use of these drugs has been declining over a period of 10 to 15 years, and it declined over 90%. And less than 1% of all presumptive pediatric TB samples, that means the samples which have been sent to detect TB in symptomatic suspected TB patients by CBNAT, and only less than 1% of that become positive. And one study done in 2006, which demonstrated the estimated annual risk of TB infection is 1/5 of that national estimate. Kerala TB elimination mission this government of US sustainable developmental goals and 0 death due to tuberculosis by 2020. And this has been envisaged as a people's movement against tuberculosis. And the theme is My TB Free Panchayat. And around 561 panchayats had 0 under 5 tuberculosis in 2019. And another 688 panchayat had 0 loss to follow-up. And also 709 panchayat had 0 drug-resistant tuberculosis in 2019 in Kerala. And overall, by and large, the standards of TB care is very good in Kerala. And as you can see here, the proportion of TB patients with multi-drug resistant tuberculosis is comparatively lower in Kerala. And also, the rifampicin resistance is less than the national average. And the reported recurrence is less than 5%. And the long-term follow-up confirms this. And the private sector follows a reasonable standard. That's a very good thing about this, about the future plans of eliminating tuberculosis in Kerala. And this Akshaya Kerala, this is, there are 10 objectives in this, and the most important ones are the TB preventive therapy to all children less than 15 years, so that we can pick up all latent tuberculosis cases and treat and prevent them from becoming active cases. So that's the most important thing to achieve our President's Action Plan, childhood free, TB free Kerala. And it will also prevent 1,000 children from getting tuberculosis every year in our state. And this service has been given at doorsteps of people. So it's a very people-friendly program, which with minimal inconvenience to the population, to the people. And we also, we are planning to decentralize the molecular test like CBNAT from 1 or 2 centers to more centers. Like, we are planning to have these centers at taluk level also. And so that early and accurate detection of all TB cases is possible. And every district should have at least 2 to 3 centers rather than 1 or 2. And many districts will have more than that. And apart from that, apart from the 48 centers in and around Kerala, we're planning to have 16 centers in the private sector also. So this is our aim, TB free air for every child. IAP has always stood for child's right, and this is one of the important one. And this already mentioned this estimated total cases given the current trend. But if we introduce this program, we can reduce it to below 5,000. And in fact, we can achieve the 0 cases by 2025. Now, TB preventive therapy. Now, prevention of active TB cases by treatment of latent tuberculosis infection is a critical component of WHO end TB strategy, and the draft national plan for programmatic management of latent tuberculosis infection developed by this national, the training work group is ready, and Kerala state has locally customized the national plan. And the necessary things to roll out these services are training of all pediatricians and other stakeholders, and the laboratory assessment, because we are moving from the tuberculosis skin test to IGRA test, which means interferon gamma release assay, which is more specific than tuberculosis skin test, and how to collect the specimen and how to transport it, and then getting the results. And the logistics also is important, like test kits, drugs, recording and reporting. And also there will be a district pediatric TB committees to, manage some difficult cases or scenarios which might come up in, after implementing this program. Now we go to the eligibility criteria for latent tuberculosis infection. This is a very important slide. As you can see, 30% of the exposed contacts of to a tuberculosis case will develop infection. 70% escape this infection usually. And in this 30%, 90 to 95% becomes persistent latent infection. And that can only be detected by our immunological test like IGRA. And 10% of these infected people will have active TB diseases in their lifetime. And in this regard, 75% of them become active TB cases before 5 years, and more than 50% in infancy. So that's the importance of identifying LTBI and treating LTBI to prevent active cases active cases coming up in the community. So the primary disease, they may have smear positive infectious, smear negative cases, and extrapulmonary also. And the development of this disease depends on the immunological status of the host. So that's the most important thing. Host immunity plays a major role here. So latent tuberculosis infection is defined as a state of continuous immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinically manifest active tuberculosis. So no symptoms will be the child will be asymptomatic, the person will be asymptomatic, and only when you test for this immune response, then only we'll be able to know the patient is having or the person is having LTBI. So from the pool of infected but asymptomatic patients, most cases of tuberculosis come up. So as mentioned in that previous slide, on an average, 5 to 10% of those infected will develop active TB disease over their lifetime, and usually within the first 5 years after initial infection. The risk for active TB disease after infection depends on several factors. The most important one is the immunological status of the host. And the risk of developing TB disease after we give treatment for TB preventive therapy or treatment for LTBI is, this is very important because it decreases 90%. That is from 11.1% for those not taking LTBI treatment to 1.2% for those those who have taken the treatment. So 90% decrease can be expected if you treat LTBI. And effective implementation of this alone would result in decline in annual TB incidence of 12%, independent of other background interventions like better nutritional management and all. Now, a series of care approach should be followed to implement this program among children and adolescents in Kerala. And it is pertinent that all children at risk of developing TB should be reached out, screened for active TB disease, and rule out active TB disease. Then they should be treated for LTBI. And Kerala, with a lower incidence of childhood tuberculosis and LTBI, it is suggested to have a test and treat approach for the management of LTBI. Now, what is a contact? Household contact. A person who shared the same enclosed living space as the index patient for one or more nights, or for frequent or extended daytime periods during the 3 months before the start of current treatment. So a person is detected to have a tuberculosis, and when another person is having a contact or stays with that person in an enclosed living space for one or more nights or more daytime periods, is a contact. He is considered as a contact. Now, who are all eligible for LTBI treatment? This is very important. The most important thing, children less than 5 years who are household contacts of microbiologically confirmed pulmonary tuberculosis may continue to be given TB preventive therapy after ruling out active tuberculosis according to the current national guideline. So less than 5 years, they should be having contact with microbiologically confirmed pulmonary tuberculosis. Second one, a child born to a mother who was diagnosed to have TB. Here, any type of TB is considered in pregnancy, and that child should receive TPT preventive therapy, provided congenital tuberculosis has been ruled out. So a mother who is taking anti-tuberculosis treatment, if she delivers a baby, the baby should get TPT after ruling out congenital tuberculosis by appropriate tests. The third one, children and adolescents 5 to 15 years who are household contacts of microbiologically confirmed pulmonary tuberculosis, they should be tested for LTBI. If found to have LTBI, they shall be offered treatment for the same. Here also, everywhere you should rule out active tuberculosis by appropriate test. Then only we need to give a treatment for LTBI. And the fourth group, children and adolescents from 1 year to 15 years living with HIV, they also should be given tuberculosis preventive therapy after ruling out TB. Here, no contact is required. So if they have HIV, they should be given TPT. And children living with HIV less than 1 year, they also should be given TPT only when they are having a contact with pulmonary tuberculosis. And of course, after ruling out tuberculosis. So less than 1 year, it should be, they should be having a contact with a case of pulmonary tuberculosis. Above that, 12 months to 15 years, they don't need a contact with pulmonary tuberculosis to treat for TPT. So here, this is a very important point, an important change. Now the sixth one, children and adolescents less than 15 years planning to have anti-TNF treatment for various reasons. Children receiving dialysis, those preparing for an organ or hematological transplant, drugs for a longer duration, that means more than or equal to 2 milligrams per kg oral steroids for more than 2 weeks. For example, nephrotic syndrome, acute leukemia, systemic inflammatory conditions, etc. They should be tested for LTBI. And if found have LTBI, they should be offered treatment after ruling out active tuberculosis. Here, no contact is required, just like HIV and children. I mean, children having HIV, living with HIV. Now, the seventh group, apart from these categories, children and adolescents on any chronic immunosuppressive conditions decided by their pediatrician, they shall be tested and treated for LTBI. So these are the 7 eligible groups for treatment or eligible for treatment of LTBI. Now, identification of eligible children for programmatic management and monitoring. Children and adolescents less than 15 years who are household contacts of all microbiologically confirmed pulmonary TB patients notified after 1st November 2020 shall be considered as eligible. Okay. And those children and adolescents shall be enumerated during household contact tracing of all microbiology confirmed TB cases by the primary healthcare team. So they will go to the houses and find out who are all eligible. Now coming to the testing for LTBI. Now LTBI treatment for household contact less than 5 years and children and adolescents living with HIV. For all other eligible children, IGRA, that means interferon gamma release assay, should be used for diagnosis of LTBI rather than our tuberculosis, the century-old tuberculosis skin test or MARA. IGRA and TST. So these are the differences between IGRA and TST. IGRA is more specific and which uses specific mycobacterium tuberculosis antigens. Tuberculosis skin test, which is not standardized and which is unquantified, and that 2-TU PPD RT23 is not available. And in IGRA, there won't be any boosting, but boosting effect will be there in TST. That means if you do a test and if you repeat it after 1 month, sometimes you'll get a false positive result. And IGRA is not affected by BCG and other mycobacterium tuberculosis, other mycobacteria. But TST is affected by BCG and other non-mycobacterium tuberculosis infection. In IGRA, only 1 patient visit is required. In TST, the patient should come after 48 to 72 hours to read the test result. And minimal inter-reader variability, but here in TST, there will be significant variability will be there. And we will get results in 1 day in IGRA, but we have to wait for 2 to 3 days. And this, as already mentioned, standardized TST is not available. So that's another problem. So comparing this IGRA and TST, IGRA is way ahead of TST and which is more specific. And but then it is costly, and that's the only issue. But later on in future, we'll have a CTB test, which also uses a specific mycobacterium tuberculosis antigen, just like IGRA, and it is also having a at par with IGRA. The specificity and sensitivity is almost equal to IGRA. So IGRA, interferon gamma release assay, you can use the lithium heparin bottle, the green capped one, and IGRA testing shall be set up at 46 public labs, 2 to 4 per district. So it is being distributed as mentioned earlier. And apart from these, 16 private laboratories will also be performing this test. National Tuberculosis Elimination Program has established specimen collection and transportation system from every peripheral health institution. Excuse me? Hello?
Faisal, you are audible.
Okay. So the peripheral health institution to transfer the samples in a hub and spoke model, because the blood should be transported for IGRA. In room temperature, only for 16 hours you can keep it. So within 16 hours, it has to reach the testing site. If in a room temperature, if it is stored in 2 to 8 degree, you can keep it for 48 hours. And from peripheral hospitals, IGRA laboratories is not co-located. Blood sample for IGRA have to be located in lithium heparin, because then only it will stay that much. That is why it is used. For instant use, it is not used. And these blood collection tubes are transported through the specimen collection and transportation system on a particular day, so as to reach the laboratory within 16 hours of collection if stored at room temperature, or within 48 hours if it is stored at 2 to 8 degree. And laboratories will be performing IGRA only on specific days. So that is also should be noted. And the steps in this operation procedure, systematic operation procedure, sample collection is very important, because it is collected in vacuum and 5 ml blood should be collected, and it should be, actually it should be, the person identification number should be legibly written, and the packing should be correct, and shipping of samples is also important. And the transfer of blood to IGRA tubes in laboratory, and then they incubate the tubes, and then post incubation they collect the plasma and do the ELISA and calculation by using a software. So the results will be available after that. So this is the pictorial representation of that. In the blood will be transferred to the IGRA tubes first. First it will be transferred to IGRA tubes, and then they incubate the tubes upright at 37 degrees centigrade for around 16 to 24 hours. And then the centrifuge tubes, they centrifuge at 1,500 to 2,200 for 5 to 10 minutes. And then the plasma is harvested from each tube, and it is stored in rack microtubes or uncoated microplates. And then the stage 2, the ELISA test is performed by using this solution, this plasma, and then it is read. So these are the various steps in the procedure of doing this IGRA, and the results will be available. Okay, right? So this is about IGRA. So the most important thing is we use IGRA test for identifying LTBI rather than TST. TST is not that specific and sensitive also. So there will be a lot of false positive results will be there in TST. IGRA is more specific. I think that's all.
Thank you, Dr. Faisal, for the clear description of rationale behind the treatment of latent TB infection in children, about the eligibility criteria, as well as which test we will use to diagnose latent TB in a child. Before going to discussion, I request all the delegates to put their concerns or doubts or suggestions in the chat box. And on guesties here, our state TB officer, Dr. Sunil Kumar, is in the group. I invite him for his comments on programmatic management of LTBA in Kerala. Sunil Kumar, sir, over to you.
Yes, sir. Yes, sir. Good evening, all. Respected IAP State President Dr. Narayanan, Dr. Balachandra, Dr. Ashraf sir, and other senior pediatricians and other faculties from North Kerala. As you are aware that Kerala is moving towards the TB elimination activities, and we started launching the TB elimination activities in 2018. But in between, we had so many hurdles. One was the Nipah, then came the COVID, and so there was a little bit delay. And now we are in the phase to move along with the COVID, and we started the TB elimination activities under the banner of Akshay Kerala. It was launched on Gandhi Jayanti Day, October 2nd, by the Honorable Health Minister. And after that, IAP has taken the initiative to show the entire country to start the latent TB management among the pediatrics group. And this is the first time in the country to adopt test and treat policy. You know that we are giving chemoprophylaxis for under 5, under NTEP for a long time. INH chemoprophylaxis. But now we are going to have a test, and based on the test result, we will be giving chemoprophylaxis, tuberculosis preventive therapy. And within a short span of time, IAP came up with guidelines, and under the leadership of Dr. Narayanan, and this was submitted to Central TB Division, and it was approved. And within a short span of time, the IAP was able to conduct the training roughly around 1,000. We are expecting by this weekend we will be able to cover the entire pediatricians in the entire state. And regarding the North Kerala, some specific issues are there, because for a long time we are monitoring the pediatrics cases in the North Kerala, where the number of pediatrics cases put on TB drugs is more when compared to the South Kerala. And for around 10 years back, State TB Cell has taken the initiative to analyze the reason, and we had visited Wayanad district, which was reported maximum number of TB cases in that quarter in the entire country. And there, so we came to know there are certain issues, and after that we arranged, along with the IAP support, we arranged sensitization, and now the pediatric TB cases are coming down through in the entire state of Kerala. And from regarding the latent TB management under IAP, still the only association that came forward at the earliest was the IAP. Thank you, Narayanan sir, for taking this initiative. And from the state TB cell, all support is assured to the IAP for initiating the latent TB among the pediatrics age group. And we do have around 56 IGRA testing centers in the public sector. And apart from the public sector, we are identifying around 10 to 15 private sectors also under partnership scheme. From the program, the money will be reimbursed for IGRA testing. And regarding the logistic support, the state has sufficient quantity of pediatrics drugs, and it will be available to public sector as well as the private sector. And regarding the sample collection, sputum pickup transportation mechanism is already in place in the entire state. Along with that sputum pickup transportation, we will be having pickup for this IGRA sample and for the testing to the nodal site. I expect that at least in one district, 2 or 3 sites may be available for IGRA testing. And the drug supply will also be given to the private sector, irrespective whether public or private sector medicine will be made available. And regarding whatever support IAP need will be assured by the state TB cell. And regarding any logistic management, we will take care. Thank you, Narayan sir, and all the pediatricians.
Thank you, Dr. Sunil Kumar. Now, Dr. Faisal clearly mentioned about the rationale of management of treatment of a latent TB infection, because we all know that 30% of the contact of a source case will develop infection. Out of this 30, 90 to 95% is a latent TB infection. So latent TB is a potential risk factor for reactivation at any time of the life. So we are treating it in order to eradicate or eliminate the TB from our country. That is the paradigm shift of the RNTC program. Now it is National Tuberculosis Elimination Program. And with the support of Indian Academy of Pediatrics, Kerala is taking a leading role. Then regarding the eligibility criteria, Faisal mentioned 6 or 7 eligibility criteria. And our plan is first to rule out active TB, then treat. That is one group. Another group is rule out active TB, investigate for latent TB infection, test for latent TB infection, and treat. But 2 policies are there. One is rule out active TB and treat for latent TB infection. That is one group. Another group is rule out active TB, test for latent TB infection, then treat for latent TB infection. The first group comes any child who is in contact of a household contact of a pulmonary tuberculosis, which is microbiologically confirmed. That is a change from the national policy. We will put the child, if the child is under the age of 5 years, after eradicating a active TB. There is no need to test for LTBA in that age group. Then second one is a baby born to a tuberculosis mother. After ruling out the active TB disease, we should put the child on the latent TB treatment. There is no need of testing in that group also. The third one is any child living with HIV in the age group of 1 to 15, we have to put the child on TB prophylaxis or latent TB treatment. There is no need of contact or there is no need of testing because they are HIV children are immunologically compromised. So you may not get a positive test. But in that group, if the child is less than 1 year, we will give latent TB treatment if there is a microbiologically confirmed pulmonary contact. In that also, we will rule out the active TB first. Then the other three in which we need rule out active disease, test and treat. One is any child, any household contact of a microbiologically confirmed TB in the age group of 5 to 15. We have to rule out the active TB. We have to test for latent TB infection and treat accordingly. The algorithm will come in next sessions. The other group is we are routinely doing that. If we are going to treat a nephrotic syndrome, we will do a Mando now. So any child we are going to treat with anti-cancer drugs on hemodialysis, or we are going to start a steroid treatment more than 2 milligram per kg for a duration of 2 weeks or more. We have to rule out a latent TB infection and active disease. And if the child is having latent TB infection, we will put the child on latent TB treatment. That is previously the prophylaxis. Now it is latent TB treatment. But these are the eligible criteria, and there is no doubt about the test, which is now under this program, it is IGRA testing, because we all know Mando is not a standardized one. Different strengths are available. So we will use IGRA, and the state TB cell will provide sufficient IGRA for next 3 months. And we are awaiting another test called CTB test, which is not available at present in India. If it is available in future, we may switch over to CTB test. Now the test is IGRA, and the availability and the modality of reaching the lab all will be discussed later. It will be shared in all of our groups. We hopefully by the end of this month, the IGRA facility will be available across the Kerala. There will not be a problem. The state TB cell taking all out measures to purchase and supply IGRA. And they are also planning to set laboratories in various places. And there will be a central collection and transport system. There will not be any worry about that. But that is about eligibility criteria and tests used. And next talk is by Dr. Ranjit. The Faisal repeatedly said that ruling out of an active disease is an important step before starting LTBI management. There is a small risk of scientifically risk on 3 months 2 drugs are latent TB infection, Oxybacillary, dormant bacillus Oxybacillary even though the program risk suppose active TB disease LTBI management there is a very remote chance to develop drug resistance. That step is very important. Dr. Ranjit, who is a pediatrician in Health Service Department, also the web editor of Indian Academy of Pediatrics, will tell us how to rule out an active TB disease. Before that, Dr. Ragesh, any comments about the first session?
Let's go to the next session, sir. The first session was very clear. Only thing is about the eligibility criteria. Like we will stick on to the eligibility criteria for including them in the programmatic management of latent TB infections.
Then we will move to second session. Dr. Ranjit, over to you. How to rule out an active TB disease, before starting a LTBI management in a child.
Good evening, everyone. Is the screen visible, sir?
It is visible. Go for slideshow. Range കുറവാണ് അർജിത്തെ.
Range.
Yes, yes. It is coming. It is coming. Yes, yes. It's okay, Ranjit. Start. പോയല്ലോ രഞ്ജിത്ത്. Okay.
PowerPoint പോയല്ലോ.
സ്ലൈഡ് ഒന്നും കൂടി ഷെയർ ചെയ്യും. Yes. Go for slideshow.
Is it seen, sir?
ഇപ്പൊ കാണുന്നുണ്ട്. എലിജിബിലിറ്റി ക്രൈറ്റീരിയയുടെ സ്ലൈഡാണ് ഉള്ളത്. നിങ്ങളുടെ സ്ലൈഡിലേക്ക് പോയിക്കോ. ഇനി സ്ലൈഡ് ഷോക്ക് ബുദ്ധിമുട്ടുണ്ടെങ്കിൽ ഇങ്ങനെ പോയാലും കുഴപ്പമില്ല. നമ്മളാരെയും ഷെയർ ചെയ്തിരുന്നോ രഞ്ജിത്തെ?
സാർ എന്നാലും ഷെയർ ചെയ്യോ സാറേ? എന്തോ ഒരു ഇഷ്യൂ.
ഡോക്ടർ രാകേഷ്, whether with
okay, I will share that
presentation ഉണ്ടെങ്കിൽ
രഞ്ജിത്ത് ഒന്ന് സ്റ്റോപ്പ് ഷെയർ കൊടുക്കും.
സ്റ്റോപ്പ് ഷെയർ കൊടുക്കാം. നമുക്ക് സ്റ്റോപ്പ് അടിക്കാം. രഞ്ജിത്ത് ഒന്ന് സ്റ്റോപ്പ് ഷെയറിംഗ് ഇട്ടെ. രഞ്ജിത്ത്,
yes sir,
സ്റ്റോപ്പ് ഷെയറിംഗ്. സ്റ്റോപ്പ് ചെയ്തോ. ഡോക്ടർ രാകേഷ് വിൽ ഷെയർ. Ranjit, it is
okay,
ready.
okay. So we are moving to the second session, that is the ruling out of active TB. As Ashok sir rightly mentioned, we had to rule out active TB before starting the TB treatment, also before diagnosing the latent TB infections. Next slide. Active TB should be ruled out any children, adolescents before initiating LTBA treatment. Apart from the usual clinical history and a clinical examination, we had to take a chest X-ray for ruling out of an active TB. And if chest X-ray shows any abnormality, the child shall be further evaluated for TB according to national guidelines. So, viewing the after seeing the chest X-ray, we can come to a conclusion that whether the chest X-ray is normal, whether it is abnormal or TB suggestive, whether it is abnormal but not TB suggestive. Then we have to move on to the clinical examination for lymph nodes, and a thorough history of signs and symptoms of extrapulmonary TB should be done. And a clinical committee, as the previous program managers mentioned, a clinical committee should be constituted at district level. It should be constituted with the help of district health administration. It will be comprising a team from medical college, a pediatrician from medical college, a pediatrician from a government sector health service, and a pediatrician from private hospitals. And there will be a nodal officer like a pulmonologist will be there in the district level, and also will be the district administrator will be there in the clinical committee, which will the clinical committee make the right decisions regarding the doubtful cases. So the clinical presentation of common forms of TB in a child. The common symptoms, as we all know, there will be a fever for 2 weeks or more duration. There will be an unremitting cough for 2 weeks or more. There will not be any weight gain. There is no weight gain despite adequate nutrition, or loss of more than 5% of body weight in the past 3 months. There will be a lymph nodes will be appear in the peripheries. There will be signs of meningitis of insidious onset. There will be abnormal spine, that is spine gibbous, and there will be any non-specific symptoms in a contact of an infectious TB case. So these are the common symptoms, that is fever more than 2 weeks, unremitting cough more than 2 weeks, no weight gain, and loss of more than 5% of body weight, peripheral lymph nodes, peripheral painless lymph nodes, meningitis, spine gibbous, or any other non-specific symptoms in a contact of an infectious TB cases. So in that cases, the algorithm, we had to as per the contact, there will be a person with or without contact with a patient with pulmonary TB in the last 2 years, and also in the weight loss category, failure of nutrition and rehabilitation in babies with severe acute malnutrition also included in the flow chart. Other clinical manifestation we have described, that is persistent fever more than 2 weeks and unremitting cough more than 2 weeks. And if the chest X-ray, as I mentioned earlier, if the chest X-ray is highly suggestive of TB, we have to do expectorated sputum examination or gastric aspirate or induce sputum for National Tuberculosis Elimination Program approved rapid nucleic acid amplification test for Mycobacterium TB. If the nucleic acid amplification test is positive, we can label it as a microbiologically confirmed TB case, and we have to do the rifampicin resistance. If it is detected, we have to reconfirm and follow the TB pathway and do the treatment. If the rifampicin resistance is not detected, treat with the first line drugs. If the nucleic acid amplification test is negative, we have to look for any other site like a significantly enlarged peripheral enlarged lymph node, and we have to get the lymph node aspirate for Mycobacterium TB examination. We have to consider repeat a nucleic acid amplification test from a better quality specimen or alternative specimen like bronchoalveolar lavage or aspirate, depending upon the availability and feasibility at the treating center or nearby center. And we can, if the NAT is negative, we can seek a review from a higher center also. So in that cases, we can, if the repeat sample is positive, if it is negative, we have to repeat test is not indicated or not feasible. We can we can move that there is no other likely alternative diagnosis. Treat as clinically diagnosed probable TB case. So as per the algorithm, we have to confirm whether it is microbiologically confirmed TB. Even if it is negative in the nucleic acid amplification test, we have to reconfirm whether repeating the test. Even the reconfirming the repeat NAT also negative, whether there is no alternative diagnosis, we have to treat it as clinically diagnosed probable TB case. Then, if the chest X-ray, it is abnormal, there is non-specific shadows, and we have to give course of appropriate antibiotics. And if the child is already received an appropriate antibiotics, we can skip this step. And after the treatment, after a course of appropriate antibiotics, if the shadow is still persisting and symptoms is still persisting, we have to move to the previous algorithm itself, that is sputum examination, gastric aspirate, induced sputum, and we have to get a microbiological confirmation. If the chest X-ray is normal, we have to evaluate for the extrapulmonary TB, and we have to consider referral to a higher center for detailed investigation for an alternative cause also. So this is the algorithm. If the symptoms is present, we have to do a chest X-ray. If the chest X-ray is suggestive, we have to do as per the algorithm, and we have to get a microbiological confirmed TB case. And HIV testing should be offered to all children diagnosed with TB. So if the chest X-ray, it is abnormal TB suggestive, we have to specifically look for certain radiological features to label it as a abnormal chest X-ray or TB suggestive X-ray. The direct signs direct signs is sharply demarcated and lobulated density or ill-defined with vague borders occupying the hilum and obliterating the hilar points. That is, we all know that the hilar markings, hilar lymph nodes are direct signs of the TB, and indirect signs are contour and caliber of the trachea will be obliterated due to the lymph nodes, the carinal lymph nodes and hilar lymph nodes, and there will be a splaying of carina, that is the widening of the bifurcation of the carina due to the compression of the lymph nodes. So there will be a direct signs and indirect signs. And most important thing is we have to get a lateral chest films also in case of suspected TB X-ray. The lateral chest X-ray it is good to visualize the retrocardiac disease and HILA, and it picks 12 to 19% of additional scars of TB, which missed in the usual X-rays. And there will be a sign described as donut sign. The donut sign means there will be a anterior posterior, there will be right and left pulmonary artery, and also there will be aortal shadows will be seen, and behind there will be a trachea. If there is a lymph node, it will appear as a donut as seen in the lateral X-rays. So that is characteristic of lateral chest film in TB. And the left lower lobes, which are usually hidden behind the heart, also better visualized in the lateral views. So if the primary diagnosis test is X-ray, in the first X-ray, we can see the lymph nodes seen in the right and left hilum. And also in the second X-ray, it is a characteristic of miliary TB. The miliary shadows are very evident in the X-ray. And the third one, there will be a fibrocavitary lesion in the right upper and left middle, right upper. There will be a fibrocavitary lesion. Also on the left side, also there will be a fibrocavitary lesion. And in the lower down, the first X-ray, we can see the lymph nodes and primary complex is seen. And also in the last X-ray, there will be a features of progressive primary TB, that is spreading of the TB cases as seen in the X-rays. In some X-rays, there will be a cavity with consolidations. As seen in the first X-ray, there is a cavity in a consolidation in the right side of the film, and also in both the other two X-rays, there is a fibrocavitary lesions in the right. Also in the left link, there will be fibrocavitary lesions are seen in the X-rays. So in extrapulmonary TB, our aim is to get a microbiological diagnosis. If there is a lymph node TB, there will be a cervical lymph nodes. There will be a chance of mandopositivity 70%. We have to do a FNAC of the lymph nodes or CBNAT from the lymph nodes to get a microbiologically confirmed tubercle bacilli. And we have to do AFB smear in the sample. And we can do MGIT, that is Mycobacteria growth indicator tube, that is to assess whether there is any resistance to the TB drugs. In MGIT, that is a Mycobacteria growth indicator tube, which detects TB bacteria, which detect the presence of TB bacteria in the whether the TB bacteria grow in the presence of TB drugs. If the bacteria grow in the tubings, that is in the presence of TB drugs, then we can claim that they are resistant to the drugs, that is a resistant TB. The Middlebrook is the culture medium used in the MGIT test. Then we can do excision biopsy and test if all other tests are negative. And in case of pleural TB, we have to get CBNAT of the sputum, and also we have to get the gastric aspirate. Pleural fluid, we have to get the pleural tissue pleural fluid we can assess, and pleural tissue biopsy we can done. If it is positive, it is the definitive confirmation of the TB. And if we analyze the pleural fluid analysis, it is an exudative efficient. It is more of a lymphocytic fluid, and it is straw colored. There may be mando positivity. Child may or may not be sick, and there is a long history of any clinical symptoms. Probably there is a pleural TB. And abdominal TB, there will be a intestinal, peritoneal, visceral TB. We have to assess it by looking at the X-rays, USG, barium studies, CT, the characteristic findings of the TBs, and also CT angiography. If there is CNS TB, there will be infects in the basal ganglia. There will be features of hydrocephalus, and there may be presence of tuberculoma. In CSF examination also, it will be clear. There will be a 10 to 100 lymphocytes count. There will be high protein ratio and CBNAT, and there will be tuberculin skin positivity will be 50%, and there is chest X-ray and chest X-ray will be suggestive. There is, we can do the CECT and contrast MRI also to confirm any features of CNS TB. In bone and joint TBs, there will be characteristic features like Pott's disease, dactylitis, osteomyelitis, arthritis, reactive arthritis. There will be features of TB, bursitis. And if you take the X-ray spine, there will be a 30 to 50% of loss of bone is seen in the bone and joint TBs. And in that scenario, bone and joint TBs, the most sensitive investigation is MRI. It is 100% sensitive in detecting the bone and joint TBs. So the diagnostic algorithm for diagnosis and treatment of LTB among HIV negative eligible children and adolescents aged 5 to 15 years. We have to, in HIV affected children, we have to screen for active tuberculosis disease. We have to look for the signs and symptoms of cough, hemoptysis, fever, night sweats, weight loss or poor weight gain, chest pain or shortness of breath, fatigue, whether child is not eating well. The features are present. We have to investigate for the active TB disease as per the NTP pediatric guidelines. If active TB disease is present, we have to treat it as active TB. If the active TB disease is ruled out, test for latent TB infections, and if positive, consider treatment of LTBA. If the symptoms are absent, as we rightly mentioned, the investigation of choice is IGRA. If it is positive, we have to do the chest X-ray as per the X-rays mentioned earlier. If it shows any abnormalities, we have to investigate for active TB disease as per the NTP guidelines. And if there is no abnormality, we have to clinically examination of the lymph nodes and history of signs and symptoms of extrapulmonary TB as we mentioned earlier. If it is present, we have to treat it as active TB. If it is absent, we have to assess the contraindications, do baseline assessment, and decide on treating of LTBA. So this is the algorithm for treating HIV, diagnosis algorithm for diagnosis of and treatment of LTB among HIV negative eligible children and adolescents aged 5 to 15 years. So in short, we have to rule out active TB. The main investigation of choice is chest X-ray, and we have to look for whether it is normal. We have to check whether it is abnormal or TB suggestive. If it is abnormal but not TB suggestive, we have to look for any alternative causes, and also we have to look for extrapulmonary TB.
Thank you, Dr. Ranjit, for that clear description how to rule out active TB disease before starting LTBI treatment. But it's very clear we are having two entities. One is latent TB infection and other is active TB disease. Latent TB infection means there will not be any signs or symptoms of TB disease, but you will get an immunological response if you are doing a Mando test or a GIRA or CTB. There will be an immunological response to TB antigen, but there will not be any symptom. So before evaluating any household conduct of a microbiologically confirmed pulmonary TB, we should ask for the symptoms first. that symptom, Ranjit, is very clearly described. That is fever, 2 weeks or more duration, cough, persistent cough, 2 weeks or more, or weight loss last 3 months, at least 5% or no weight gain last 3 months. For the extra pulmonary TB, lymphadenopathy or a gibbous or an insidious onset of meningitis. But one point is very important. Any non-specific symptom in a household contact of an active TB, we should rule out active TB disease. അപ്പോൾ ആക്റ്റീവ് ടി ബിയുടെ ഒരു കോണ്ടാക്ട് ആണ്, ചെറിയൊരു ഫീവറെ ഉള്ളൂ, ഫാദറിന് അല്ലെ ഗ്രാൻഡ് ഫാദറിന് മൈക്രോബയോളജിക്കലി കൺഫേംഡ് ടി ബി ഉണ്ടെങ്കിൽ ഈവൻ 5 വയസ്സിന്റെ താഴെ ആണെങ്കിലും ഒരു എക്സ്റേ എടുക്കുകയാണ് നല്ലത്. ഇഫ് എക്സ്റേ ഷോസ് highly suggestive features like lymphadenopathy or miliary mottling or fibrocavitary tree, we will send for the CBNAT. CBNAT positive, that is a microbiologically confirmed TB. Suppose CBNAT go negative, CBNAT is not positive, we can repeat the sample, we can refer that child to an expert if we are suspecting TB clinically. So repeat the CBNAT ചെയ്യാം, വേണമെങ്കിൽ ബ്രോങ്കോഅൽവിയോളർ നോക്കാം. ഇനി അതിൽ മറ്റേ ഹൈലി സജസ്റ്റീവ് എക്സ്റേ ആണ്, CBNAT 2 പ്രാവശ്യം ചെയ്തിട്ട് നെഗറ്റീവ് ആണ്, പക്ഷെ വേറെ ആൾട്ടർനേറ്റ് ഡയഗ്നോസ് ഒന്നും ക്ലിനിക്കലി നമുക്ക് തോന്നുന്നില്ല. ആ ഒരു റയർ ഇൻസ്റ്റൻസിൽ ഈവൻ ക്ലിനിക്കലി ഡയഗ്നോസ്ഡ് TB ആയിട്ടും അത് ട്രീറ്റ് ചെയ്യാം. സോ these 2 points are important. There will not be any symptoms or signs for the TB disease, for latent TB infection. And the first, to rule out active disease, first we should ask for the symptoms. After the screening for the symptoms, we will take an X-ray. പിന്നെ 5 വയസ്സിന്റെ താഴെ സിംറ്റംസ് ഒന്നും ഇല്ലെങ്കിൽ നമുക്ക് നേരെ LTB ട്രീറ്റ്മെന്റ് തുടങ്ങാം. 5ന്റെയും 15ന്റെയും ഇടയിൽ ഈ രണ്ട് ഗ്രൂപ്പാണ് ഏറ്റവും കൂടുതൽ നമുക്ക് വരിക. 5 to 15 years, we have to, if the child is symptomatic, rule out active TB. If asymptomatic, നമ്മൾ ഇഗ്ര ചെയ്യുന്നു. ഇഗ്ര പോസിറ്റീവ് ആകുമ്പോഴും നമ്മളൊരു എക്സ്റേ എടുക്കുന്നു. അതാണ് ഇമ്പോർട്ടന്റ് പോയിന്റ്. ആ എക്സ്റേയിൽ ഒരു മീഡിയാസിൽ നോഡ് ഉണ്ടെങ്കിൽ ബാക്കി കാര്യങ്ങൾ ചെയ്യാം. അതായത് ഹൈലി സജസ്റ്റീവ് ഫീച്ചേഴ്സ് ഉണ്ടെങ്കിൽ അത് നമ്മളൊരു ആക്റ്റീവ് TBയെ ലേറ്റന്റ് TB ഇൻഫെക്ഷൻ കൊണ്ട് ട്രീറ്റ് ചെയ്യരുത് എന്നുള്ള ഒരു കരുതലാണ് ആ ഒരു സ്റ്റെപ്പിൽ കൊണ്ടുവന്നിരിക്കുന്നത്. Please remember that algorithm. Then there are certain questions in the chat box. We will do the questions at the end of the session, because next session is by Dr. Mridula,
yes, sir.
Consultant Pediatrics in District Hospital Kannur. She will tell us how to treat latent TB infection in children. Mridula, over to you.
Thank you, sir.
One minute, Mridula. Dr. Ragesh, I forgot about you. Anything, എന്തെങ്കിലും പറയാനുണ്ടോ? സ്ട്രെസ് ചെയ്യാൻ എന്തെങ്കിലും ഉണ്ടോ രഞ്ജിത്തിന്റെ?
ഒന്നുമില്ല സാർ, ഒന്നുമില്ല സാർ. ഇത് തന്നെ സാറ് പറഞ്ഞതിന് കൂടുതൽ ഒന്നും പറയാനില്ല.
ഓക്കെ ഡോക്ടർ മൃദുല.
Rakesh sir, please do the slideshow for me. So after the detailed account of latent TB infection, we abbreviate as LTBI, by the eligibility criteria as explained by Dr. Faisal. The next step, we did the ruling out of active TB disease. So this ruling out of active TB disease is there in every step of assessment for LTBI. So from the beginning towards the end, in every step we are doing the ruling out of active TB disease. So as we all know, LTBI is a state of persistent immune response to Mycobacterium TB antigen, and there will not be any clinically manifest disease. So the importance of treating LTBI, as initially stressed by Ashraf sir and later presented by Dr. Faisal, that is, if we treat the LTBI, the risk to develop into active disease is reduced by 90%. So the usual risk is 11.1%, and it is reduced to 1.2% if we decide to treat the LTBI. So the treatment is also called as TB preventive treatment, abbreviated as TPT. So going directly to the treatment per se, we have 4 regimens available as options. The first one is 6 months of INH, which all of us are familiar with. The second one is 3 months of INH and rifampicin. And another one is 4 months of rifampicin. And another one is weekly rifampicin with INH for more than 2-year-old. So the last one is not available yet in the program. Now, among the 4 options I mentioned, which one do we opt? The preferred regimen in Kerala is all eligible children and adolescents less than 15 years who were diagnosed to have LTBI shall be provided treatment with a 3 months daily dose of INH plus rifampicin after ruling out active TB. So, stressing on the important points, 3 months of daily dose. So 3 months daily dose INH plus rifampicin. This is what we are going to implement from this month onwards. Now, next. So why did we opt for the 3HR regimen? So there is comparatively lower risk of adverse effects compared to longer duration of INH alone regimen. As we all know, the adverse drug reaction of INH is related to the duration of treatment. So the risk is comparatively lower in a 3-month regimen. And there is a chance of greater adherence due to shorter duration is quite obvious. Then familiarity of use for pediatricians, both the drugs are familiar to the pediatricians. Then availability of child-friendly fixed dose combinations, abbreviated as FDC, fixed dose combination. So, and in a place like ours, Kerala, we have adequate system, very strong health surveillance system, and it is very easy for us to roll out active TB. So because of all these reasons, we have opted the 3HR regimen for tuberculosis preventive treatment. Now, so what are the available evidences for the treating regimen that we have opted? The efficacy and safety profile of 3 to 4 months daily rifampicin plus INH, that is the regimen we have decided. So the efficacy and safety were similar to those of 6 months INH in treatment of LTBI. Next one is RCT, reported no clinical disease. That is clinical disease as assessed by radiographic findings suggestive of active TB. So it is shown that fewer participants given daily rifampicin plus INH than those given 9 months of INH alone therapy developed radiographic changes. That is, fewer patients in the combination therapy developed clinical disease as evidenced by radiographic findings. The authors also reported a lower risk of adverse events and a higher adherence rate in children given daily rifampicin plus INH. So our regimen is clearly evidence-based. Now, coming to the next, the treatment as such. The regimen is INH plus rifampicin daily for 3 months. So it's a daily regimen, INH plus rifampicin for 3 months. The dose being INH in age 10 years and older, 5 milligram per kg per day. And in less than 10 years, it is higher dose, 10 milligram per kg per day. The range being 7 to 15 mg. The dose of rifampicin, age 10 years and older, 10 mg per kg per day, and age less than 10 years, it's a higher dose of 15 mg per kg per day. The range being 10 to 20 milligram. So, dose of rifampicin plus INH, fixed dose combinations according to weight bands. So the fixed dose combination, as you can see in the slide, the rifampicin 75 mg and INH 50 mg, that is the FDC available for us. And we have 4 weight bands, actually 5 weight bands. 4 to 7 kg, 8 to 11, 12 to 15, 16 to 24, and more than 25. And the number of tablets we have to give is 1, 2, 3, 4, and more than 25 kg use adult formulations. Now, regarding pyridoxine supplementation, as we all know, a very serious adverse drug reaction to INH is peripheral neuropathy. So it is because of INH interfere with the pyridoxine metabolism. So pyridoxine supplementation, 10 to 25 mg daily for more than 3 months of INH is recommended. So we are giving pyridoxine along with the LTBI treatment regime. So the risk of peripheral neuropathy is more, especially because we are opting a higher dose of INH in the treatment of LTBI. And the peripheral neuropathy often goes undetected in young children. Also, peripheral neuropathy is more common in malnourished children and also HIV infected children. So individuals at risk for peripheral neuropathy, that are malnutrition, HIV infection, renal failure, or diabetes, should receive vitamin B6 supplements when taking INH containing regimens. Additionally, exclusively breastfed infants should receive vitamin B6 while taking INH. Next one. Now, what are the contraindications for TB preventive therapy? So the first one is contacts of any drug-resistant TB. So drug-resistant TB is a different entity, and the contacts may be given individualized preventive treatment as per the drug sensitivity profile of index case as decided by the district pediatric clinical committee, which will be constituted in every district, and with a regimen which should be approved by the National Technical Working Group on programmatic management of LTBI. So drug-resistant TB, we have to refer to the district opinion, refer for the opinion of the district pediatric clinical committee. Then another contraindication is active hepatitis, either acute or chronic. If the hepatitis is active, it is a contraindication. Then symptoms of peripheral neuropathy. So in both these, we have to clinically assess the child and do any investigations as necessary and decide about LTBI accordingly. We have to weigh the risk of developing an active disease with the harm caused by the medicines and decide about the LTBI treatment. Now this slide already explained by Dr. Ranjit. So it is about the diagnostic algorithm for diagnosis and treatment of LTBI among HIV negative eligible children and adolescents aged 5 to 15 years. Why we are in this slide? Because only in this group of children, we are going to test for LTBI, that is using the IGRA test as of now. So initially we should screen for active tuberculous disease. And if it is present, we have to follow the NTEP pediatric guidelines. And if it is absent, we should do the IGRA test. And if the IGRA is positive, again, we are in the next step also, we are ruling out the active TB disease. We are taking a chest X-ray, and even if there is no abnormality, we have to check for clinical examination for lymph nodes and history of signs and symptoms of extrapulmonary tuberculosis. So every step we are doing the ruling out of active TB. So finally, we assess the contraindications, do baseline assessment, and start the treatment. The next one also, Dr. Rakesh, the next session also.
Okay, right.
So, that is about the treatment per se. And now coming to the baseline assessment and initial counseling. So once we decide to treat the patient, so initially eligible children we identified, ruled out active disease, and when we before we decide to treat, then we do the baseline assessment. which are the points to be checked? History of any drug allergy, whether the child is on any other medications, which could be, there could be interaction with the our drugs. Then contact with drug resistant TB, I already mentioned. Then potential contraindications of LTBI drugs. Then assessment of any comorbidities like malnutrition, HIV infection, or diabetes mellitus. Then assessment of social and financial situation of the family to arrange essential support in coordination with primary healthcare system. So this is very important. Once we decide to treat, we have to assess the social and financial situation of the family. Because the next point is treatment supporter. Assess if a treatment supporter outside family is needed. Because our daily treatment with 3HR is supervised as family dots. So we need a treatment supporter. So whether such a person could be identified from the family itself, or do they need anyone, any support from outside, which we can arrange in coordination with the primary healthcare team. Then testing of liver enzymes at baseline to be done. This is very important. We are doing a testing of liver enzymes at baseline. Next one, sir. So in the initial counseling, we have to counsel the parents because our patients are children. So we have to tell them the rationale for LTBI management and the benefits not only to the individual, but for the household and the whole community. Then LTBI management is available free of charge through national programs. Then LTBI management regimen prescribed, including the duration, directions for intake of medicines, and follow-up schedule. So all these should be there in the initial counseling. And potential side effects and adverse events involved and what to do in the event of various side effects. So when we explain about the side effects, there will be a question about then why to give such a treatment. So in that case, we can explain about the rationale of LTBI treatment. Now, the importance of completing the full course of LTBI management. If the child should get the benefit with LTBI treatment, it is very important that the child complete the full course of management. Then reasons and schedule of regular clinical and laboratory follow-up for treatment monitoring, which will be elaborated by Dr. Naik sir in the next session. And signs and symptoms of TB and advice on steps if they develop symptoms of TB. So I think that finishes that session, sir. Yes.
Good. Mridula, thank you.
Yes, sir.
Thank you.
Thank you, sir.
The three important carry-home messages from the Dr. Mridula's talk is, one is, don't treat if the contact, don't give LTBI treatment at basic pediatrician level if the contact is a drug-resistant TB. That is very important. The decision on the drug-resistant TB will be taken by the district committee, either the pediatric committee in consultation with there is another committee to deal with the drug-resistant TB at every districts. So it is up to them to decide what drug to be given. The second is, along with the prophylaxis, along with the LTBI treatment, whether we have to give pyridoxine or not. That point is also clear. If the duration is more than 3 months, we have to give pyridoxine. Being it is 3 months, it is not necessary in all children. But in malnourished children, we have to give. Then look for the toxicity. So one of the important point of discussion during the drafting session of this module is whether we have to send an LFT or a SGPT prior to start. For the Kerala program, it is also a baseline liver enzyme studies is desirable. Karnam, we are giving a prophylactic drug. We are not treating a disease. It is like immunization. We all know if an adverse reaction, even though it is a mild adverse reaction after the immunization, the parents will become very panicked. So it is better to do a baseline enzyme level before starting the treatment. That is clear. There are some more questions in the chat box. We will deal all after the fourth session. Dr. Ragesh, anything to add?
Nothing, sir. We'll go to the next session. So we'll take all
We'll go
the
to the next
discussions
session.
and
Next
comments at
session
the
is the
end.
last session. The program also emphasizes the follow-up of these children. We are starting the LTBI treatment and monthly follow-up them. How we will counsel and follow up a child who is put on LTBI management. The session is by Dr. Narayan Naik. He is the senior consultant in pediatrics in Government Health Service, now working in GH Kasaragod. Over to you, Dr. Narayan Naik.
Thank you, Ashraf sir. Respected IAP President Dr. Narayanan, Secretary Balachandar, Ashraf sir, District State TB Officer Sunil Kumar sir, Dr. Rakesh, my teacher C.K. Sasiran sir, Dr. Vijay Kumar, past President Dr. Santosh, and all IAPians who gathered here. First of all, I thank IAP Kerala for giving me this opportunity to present this session. Rakesh sir, will you share the slides?
Yeah, sure. I will do that.
Yeah. Up to this, we have discussed about the how to identify the cases, how to decide whether there is acute TB or not, and then IGRA test, then latent TB diagnosis and the treatment and initial counseling, and all these things we have discussed. Now we are going to know the adverse events and how to monitor those things and how to adhere to the treatment and how to complete the preventive treatment. Adherence to the LTBI therapy is of paramount importance, and completion of the entire course leads to clinical benefit, both individual and population levels. Irregular or inadequate treatment reduces the protective efficacy of LTBI regime, further increases the risk of individual developing TB disease, including drug-resistant TB. Efficacy of LTBI management is greatest if at least 80% of the doses are taken within the duration of a regimen. This 80% means we are giving 3 months course. Out of the 3 months, there is 12 weeks, means 84 doses. Of the 84 doses, at least 68 doses that child should get. Then only we call it as 80% of the treatment. The total number of doses taken is a key determinant of the extent of TB prevention. Next slide. The children on LTBI regimen shall be followed up through primary healthcare system in public sector or through STEPS model in private sector. Treatment shall be under supervision. Usually the treatment we used to give is supervision is from the mother or one of the family member. But if a family requests external support on assessment, a treatment supporter from community shall be arranged. Treatment supporters shall look for adverse events and monitor adherence daily. Primary healthcare team assesses the need for family. The family may be linked to treatment supporter groups by the primary health center care team if the family requests any assistance or support for completing the treatment. Next slide. The treatment supporter, what he needs to do is to mark a tick against each dose of the LTBI treatment in the card. If the child is not taking the drugs, that means that day there is no need to put tick mark in the card. So LTBI treatment card shall be reviewed every week by the primary healthcare team and update the information in LTBI application. Ritual action shall be taken by the primary healthcare team if the treatment interruption occurs. Next slide. And this is a very important thing, the monthly clinical follow-up. The medical officer in charge of that area, he should do the monthly follow-up at least once in a month and look for the following. And in monthly follow-up, we have to see the 3 A's. Appearance of signs and symptoms of the TB disease. Then adverse reactions, especially symptoms and signs of hepatitis. And adherence to the prescribed regime. Elicit reasons for any missed dose
and extend the necessary support to enable future adherence to the LTBN. These 3 A's we have to remember: appearance of signs and symptoms, adverse reactions, and adherence to the prescribed regime. Any adverse reactions shall be recorded in the treatment card. Adverse events also need to be reported through Pharmacovigilance Program of India. Family where children of LTB management need to contact healthcare worker provider treatment support if they notice adverse events such as anorexia, nausea, vomiting, abdominal discomfort, persistent fatigue or weakness, dark colored urine, pale stools, or jaundice. These are the symptoms of liver failure. These are suggestive of liver injury and require urgent evaluation under the medical officer. Relevant investigation need to be done as clinically indicated. Next slide. Then monitoring indicators, treatment outcome, and long-term follow-up. Yes, next slide. In monitoring indicators, we have to identify the children, eligible children, and out of the eligible children, we have to see how many % of the children are tested for LTBI infection, and out of the tested infection, how many are diagnosed to have LTBI, and out of the diagnosed, how many are eligible for preventive treatment, and out of the eligible for preventive treatment, how many are initiated on treatment, and how many of them are completed the treatment. All these things we have to monitor. Next slide, please. This is an important slide. In this treatment outcome, we are deciding the treatment outcome. Treatment completion means, as I already mentioned, a child bar adolescent initiated on LTBI management who complete at least 80% of the recommended dose. That is, out of the 84, 68 doses consumed within 120% of the planned LTBI management duration. That means within 100 days, that child should consume at least 68 doses. That means we can say it as treatment completion. If the treatment failed means a person initiated on LTBI management who developed TB disease any time while on LTBI management course. And died means a person initiated on LTBI management who died for any reason while on LTBI management course. Lost follow-up means LTBI management interrupted by person for 4 consecutive weeks for 3HR. LTBI management discontinuation due to toxicity. A person who LTBI management is discontinued by clinician due to adverse events or drug-drug interactions without treatment completion. Not evaluated, such as records lost, transfer to another health facility without record of LTBI management. This we call it as not. In this, very important is treatment completion. That child should get 80% of the recommended dose to call it as treatment completion. Next slide, please. And long-term follow-up. All children, adolescents who are household contacts of primary TB shall be followed up every quarter by the primary healthcare team looking for development of active TB symptoms. The same vigil shall be continued for all children and adolescents who were diagnosed with LTBI even after those who completed treatment. That is very, very important. Those who completed treatment means we can't stop there. We have to follow up them for a long term. If any child initiated on LTBI later develops TB, tests for detecting resistance to INH and rifampicin shall be offered at baseline if a biological specimen is available. That means if the child is on LTBI treatment and develops TB means there will be drug resistance. For that, we have to see the there is drug resistance. We have to get a biological specimen and do the Sebinet test. Okay, next slide. Prevalence of LTBI among children and adolescents who are household contacts of pulmonary TB and a clinically vulnerable group. Adverse events among children receiving LTBI treatment. These are the evident generation we have to do. Facilitators and challenges during the entire process. Follow up all these children for 5 years and study development of active TB and drug. We have to follow up all these children for 5 years. Next slide. And flow of events, identification of the eligible children, contact tracing, testing of for LTBI, rule out active TB, baseline assessment, initiation of LTBI treatment, adverse event monitoring, and ensuring treatment adherence, monthly clinical follow-up, declaring treatment outcome, and long-term follow-up. Next slide. In this previous district district pediatric TB committee, there will be a committee formed to decide if there is some doubt about regarding the treatment. If a pediatrician or any treating doctor, if he has any doubt, there will be a district TB committee. This district TB committee comprises of 5 members, of which one is from medical college, and one from health service, and one from private sector. And DMO will be the in charge, and there will be chair, vice chairman, all nominated by the DMO, and the consultant pulmonologist of district TB center shall be the convener for the committee. Any doubts regarding the treatment or any issues regarding the treatment, that committee will decide and guide you if you have any problem in dealing with any of these cases. To oversee the practices regarding the pediatric TB management in the district through a peer audit system, and give recommendation for the improving the standards of care. To oversee and suggest recommendations to the district authorities related to the program implementation for ensuring the every child receives the TB service as envisaged. And to help the clinicians to arrive at a final decision in any clinical dilemma related to the pediatric TB or LTBI management. Next slide. Frequency of monitoring meeting could be in online platforms at frequency of once in a month, or as and when required. At least 3 members are required for the quorum. Next. And any queries related to decision making shall be referred to the committee by any modern medicine doctors, formally to chair or convener, with the detailed and sufficient clinical records. Committee shall give their clinical opinion in a documented manner. Apart from this, committee will do peer audit at least 2 pediatric TB bar LTBI on every sitting, based on right diagnosis, right drugs, right dose, right duration, and right frequency. All these things will assess in comparison to the standards set by the IAP bar and TEP, and give feedback to the clinician. The entire exercise is purely a measure for quality and standard improvement. The committee will give feedback to the district authorities periodically regarding the measure to be taken to improve the program in the district. Next slide.
Thank you. Thank you. Thank you.
Thank you, sir. Over to Ashraf. Thank you.
Presentation, for the nice presentation about the follow-up of children. And he conveyed 3 things are important in the follow-up. One is adherence to the treatment. Second is any appearance of symptoms of TB. And third one is the adverse reactions. These 3 A's are important: adherence to treatment, appearance of symptoms of an active TB, and adverse reactions. We all know the hepatitis due to ATT is usually develops in the initial phase of the ATT, especially during the first 2 months. So look for that and deal accordingly. And he also said about a district level committee. If there is any clinical dilemma, any problem regarding the latent TB, management of latent TB infection, or a management of a TB disease, you can refer it. The committee will meet on online platform and give a recommendation for that. So there will be a committee in every districts. Now there are some questions. I will come to Dr. Ragesh after dealing these questions. There are some interesting questions in the chat box, and Ragesh, please correct me if I go wrong answering some queries. One is queries by Dr. Azhar. Incidence of TB with isolated weight loss or no weight gain in children. Several studies shows 30 to 60% children with TB may have weight loss. It may be a solitary symptom or maybe in association with the cough or fever. Ragesh, anything to add on that?
Nothing, sir, because when we are evaluating for weight loss or no weight gain, we need to keep TB in mind as a differential diagnosis. That's the point that we need to keep in mind.
That is the point. Any child we are evaluating for a failure to thrive, we should consider TB as a possibility, especially if there is a history of contact. That contact may be pulmonary or even extrapulmonary. For the latent TB management, now we are taking only pulmonary microbiologically confirmed cases. Okay, then another question is from Dr. Dilna Talasheri. Why no ADA?
Sir,
Why?
one thing about that, sir.
Tell.
Sir, about that, about TB. TB disease was initially in last century called a phthisis. Phthisis means, that weight loss, that condition called phthisis. So TB causes malnutrition. Malnutrition itself causes TB. So it's a, what do you call that, circle
Faisal,
is going
little
on.
more louder,
So,
Faisal.
yeah, see, malnutrition producing tuberculosis because of the, the immunity, the CMI is very weak in children with malnutrition.
Yeah.
Cell-mediated immunity is very weak. So they can develop tuberculosis very easily, children with malnutrition. And TB can itself produce malnutrition.
Yeah.
So that's the point here. And we won't get a causal relationship between malnutrition and TB because various factors are involved. Even micronutrients like vitamin D is all implicated in developing tuberculosis in children with malnutrition. Okay. Okay, sir.
Okay, that's a very good point. Especially in a malnourished child, there may be a disseminated tuberculosis, serious conditions like tuberculosis meningitis, etc. Then the second question is about the ADA. Usually ADA is used in the case of pleural effusion. It is in adults, there are a lot of comparative studies between the tuberculosis effusion and malignant effusion. And it may be useful in adults. But in pediatric age group, there is no such studies. And in pediatric age group, the two common causes for pleural effusion is one is pyogenic effusion and another is tuberculosis effusion. There is not much comparative studies between these two. So it is not very useful in diagnosing TB in pediatric pleural effusion. Ragesh, anything to add on that?
Sir, clear.
Okay, then next question is, it will be useful if TB-free air comes out with it will be useful if TB-free air comes out with short flyers for practicing pediatrician on these topics. Now itself, Dr. Ragesh is sharing in our group lot of flyers. We will come with that. Isn't Ragesh?
Sir, IAP president has requested state TB officer formally for having printed flyers to be kept in every pediatrician's consultation room. So that has been approved by the state TB officer. So jointly IAP and state TB cell will be coming out with flyers which can be kept at the tabletop or in the consultation room very shortly.
Another question is, what about patient developed hepatitis or peripheral neuropathy in between the treatment of LTBI? Cautiously. This is not for the treatment of a TB disease. It is only a prophylaxis. Polio eradication program. Immunosuppressed OPV polio eradication. To begin with, suppose a child develops hepatitis after starting prophylaxis. For the time being, it is better to stop. At this level, at this time, we are not thinking about the alternate regime, which may come in future. Ragesh?
Right, sir. So, as you rightly said, we need to weigh the risk versus benefit. If we think that the child need to be treated, and despite these adverse events, that's possible. There are facilities. We can refer to the district committee. We can look for alternative regimens, which we can try. But as sir rightly pointed out here, we are on a safer side. When we roll out such a program, we try to be on a safer side because we are dealing with healthy children. Their only problem is they are having an LTBI and they have a chance of developing into TB. So let us be on the safer side. Think like vaccines. So what we do if the child is having issues with a pentavalent vaccine, what will we do with the next dose? Yes, if you think the pediatrician feels that we need to continue that, yes, we have the alternatives. We have the systems now. Refer to the district committee. We can take decisions there and go ahead with that. But at the same time, if you think the adverse events are going to be more, then let's not be very what we say. Let's not compel the family to take the entire course of drugs at the initial period. So especially in Kerala.
Thank you, Dr. Rakesh, for that clarity. But for the time being, Narayanan, endo samsarikenda unmute cheyano. For the time being, angane oru problem vannal, it is better to reference district level committee. If the adverse effect is due to rifampicin, even we opt for a 6 months INH in case to case basis, that decision will be taken by the district level TB committee. And Rakesh Paranada, we are organizing some follow-up studies. For the due course of time, നമ്മുടെ INH rifampicin ഒരു significant number toxicity develop ചെയ്യുന്നതായിട്ട് കണ്ടുപിടിക്കാന്ന് വെച്ചാൽ അന്നേരം നമുക്ക് ആലോചിക്കാം. പക്ഷേ we are not expecting that. Then it is better to give per kg dose rather than going by fixed dose band to avoid hepatotoxicity, especially by the pediatrician. That is a comment. It is better to give per kg dose rather than going by fixed dose band to avoid hepatotoxicity, especially Rakesh.
Yes, sir. I totally agree that we need to look at the kg, like kg per dose. There is no doubt in that. But for a long time, like loose drugs also are available. We will find it very difficult to get these loose drugs in the fixed bands. So the child need to take 2 drugs, make it breakable into different formats, or it was difficult. So IAP has raised the voice for a long time for getting these fixed dose combinations for children, and now it's available with the program. The weight bands are very narrow, so that even for TB treatment and all, weight bands are very narrow. If you look at it's just 4 to 7 kg. Other weight band is just 7 to 11 kg. So weight bands are very narrow. There are 4 different weight bands, 6 different weight bands we have. So these narrower weight bands with fixed dose combinations are actually more comfortable for treating clinicians for prescribing drugs and more comfortable for children for taking drugs also. At the same time, if the clinician feels that they need to go with the individual drugs, again, fine. There are options available. Loose drugs are also available with the program.
Then next question is, rifampicin plus INH for LTBI combination, is it raises drug resistance in the society? Any study conducted? Rakesh,
Right, sir. So I will take this question. Yeah, sir. One thing is we are giving drugs to the children after ruling out active tuberculosis. I repeat, we are giving the drugs to children after ruling out active tuberculosis. If we are giving these drugs only for treating latent TB infection, as we all know, is a very, very possible condition, and chance of developing resistance in treating LTBI is absolutely nil. Basically, it's nil. That's what all the studies shows. But only risk there is if you are giving these drugs in a child with active tuberculosis, then there is chance of developing drug resistance. So I repeat, if you are giving this INH and rifampicin alone in a child with active tuberculosis, there is risk of developing rifampicin resistance. For treating LTBI, after ruling out latent TB infection, after ruling out active tuberculosis, there is absolutely no risk at all. It's only a very theoretical minimal risk remaining.
Next question is from Dr. Vijay Kumar. If the baseline SGPT is high, will we start treatment with another non-hepatotoxic drug? Any guideline? What is the upper limit for ALT and AST? The National Tuberculosis Control RNTCP guideline പ്രകാരം ഒരു ATT ട്രീറ്റ്മെന്റിലുള്ള കുട്ടിക്ക് ഒന്നെങ്കിൽ ബേസ്ലൈനേക്കാളും 5 times ALT റൈസ് ചെയ്യുക, അല്ലെങ്കിൽ റൈസ് ഓഫ് ALT or AST 3 times with symptoms, or rise of serum total bilirubin more than 1.5 per 100 ml. ഇതാണ് ഹെപ്പറ്റോടോക്സിസിറ്റി എന്ന് പറയാം. അപ്പോൾ ഒരു അസിംപ്റ്റമാറ്റിക് ചൈൽഡില് ബേസ് ലൈനേക്കാളും 5 times റൈസ് ചെയ്യാം. സിംറ്റമാറ്റിക് ചൈൽഡ്, ദാറ്റ് മീൻസ് നോസിയ, വൊമിറ്റിംഗ് അങ്ങനെയുള്ള ഒരു കുട്ടിയിലാണെങ്കിൽ 3 times റൈസ് ചെയ്യുക, അല്ലെങ്കിൽ ബില്ലിന് ബിൽ 1.5 മേലെ പോവുക. അപ്പോൾ നമ്മൾ റീസ്റ്റാർട്ട് ചെയ്യുമ്പോഴും അങ്ങനെയാണ്. നമ്മൾ ഡ്രഗ് നിർത്തി കഴിഞ്ഞതിന് ശേഷം ഒരു LFT STPT ഒരു 2 times ബേസ് ലൈൻ ആയി കഴിഞ്ഞാൽ നമ്മൾ വീണ്ടും ഡ്രഗ് സ്റ്റാർട്ട് ചെയ്യാൻ തുടങ്ങും. അപ്പം അതാണ് അതിലുള്ള ഒരു റെക്കമെൻഡേഷൻ. അപ്പം STPT നമ്മൾ സ്റ്റാർട്ട് ചെയ്യുമ്പോൾ ഹൈ ആണെങ്കിൽ ഇറ്റ് ഈസ് ബെറ്റർ നോട്ട് ടു സ്റ്റാർട്ട്. ഒരു 2 times or 3 times ബേസ് ലൈൻ ഹൈ ആണെങ്കിൽ എന്തായാലും സ്റ്റാർട്ട് ചെയ്യേണ്ടെന്നാണ് നമ്മുടെ ഗൈഡ് ലൈനിൽ. അത് പ്രത്യേകിച്ച് പറഞ്ഞിട്ടില്ല. എൻ്റെ ഒരു സജഷൻ അതാണ്. രാകേഷ് ഓൾസോ വിൽ
Agreed, sir. Agreed, sir. If it was active tuberculosis, then definitely yes, sir. We need to treat the child at any cost because it's an active tuberculosis. But now it's a preventive therapy. It's what we are giving is a TB preventive therapy. So itself, we need to weigh the risk versus benefit. That's what we always say. If you think that the treatment of this condition is going to cause more harm than the benefit, then better withhold. At the same time, hepatotoxic regimens are being recommended by the National Technical Working Group. We will wait for that recommendations. Once the recommendations are out, again, as you said, we can go for hepatotoxic regimens. For example, levofloxacin for 6 months. So these kind of regimens are being, evidences are being generated around the world, and National Working Group is coming out with such recommendations. So we will consider treating with more hepato-friendly drugs in such cases. For the time being, this is what Dr. Ashraf has said is what we need to follow.
Then, thank you, Rakesh. Another question is, INH prophylaxis for 6 months, completed in August 2020 for a 4-year-old kid. Now contact with another positive adult patient. Child is asymptomatic, grade 1 PEM, chest X-ray normal. What should we do? ഇന്നലെയും കോട്ടയം ഡിസ്കഷനിൽ ഇതേ പോയിന്റ് ഉണ്ടായിരുന്നു. 1 വയസ്സിൽ നമ്മൾ ഒരു ഫാമിലിയിലെ ഗ്രാൻഡ് ഫാദറുമായിട്ടൊരു കോണ്ടാക്ട് വന്നു. നമ്മൾ പ്രൊഫൈലാക്സിസ് സ്റ്റാർട്ട് ചെയ്തു. പിന്നെ 4 വയസ്സാവുമ്പോൾ കുട്ടിയുടെ ഫാദർ വീണ്ടും മൈക്രോബയോളജിക്കലി കൺഫേംഡ് TB ഡയഗ്നോസ് ചെയ്യാണ്. അപ്പോൾ പെർ ദി നാഷണൽ ഗൈഡ് ലൈൻ ഒരു പ്രൊഫൈലാക്സിസ് കൂടി കൊടുക്കണം. അപ്പൊ ഈ കേസിൽ PM കൂടി ഉണ്ട്. അപ്പോൾ it is better to exclude the active TB. Chest X-ray normal ആണ്. വേറെ പ്രോബ്ലം ഒന്നും ഇല്ലെങ്കിൽ പ്രൊഫൈലാക്സ് കൊടുക്കണം. പക്ഷെ ഇതേപോലെ വേറെ ഒരു ഇഷ്യൂസ് ഉണ്ടാവും ചിലപ്പോൾ. നമ്മള് പിന്നെ നെഫ്രോട്ടിക് സിൻഡ്രോമിന് ഒരു 3 വയസ്സിൽ സ്റ്റീറോയിഡ് സ്റ്റാർട്ട് ചെയ്യുമ്പോൾ നമ്മൾ ഇഗ്രാവർ മാൻഡോ പോസിറ്റീവായി നമ്മൾ പ്രൊഫൈലാക്സിസ് അല്ലെങ്കിൽ LTB ട്രീറ്റ്മെന്റ് കൊടുത്തു. ഒരു 9 മാസം കഴിഞ്ഞപ്പോൾ വീണ്ടും നെഫ്രോട്ടിക് റിക്കർ ചെയ്യാണ്. പക്ഷെ അവിടെ ഒരു കോണ്ടാക്ട് ഒന്നും ഇല്ലെങ്കിൽ അവിടെ വീണ്ടും കൊടുക്കേണ്ടതില്ല. ഈ കേസ് അങ്ങനെയല്ല, വീണ്ടും ഒരു റിസ്ക് ഉണ്ട് റീഇൻഫെക്ഷന്റെ. അപ്പൊ ഇറ്റ് ഈസ് ബെറ്റർ ടു ഗിവ് കട്ട് ദ കൗൺസിൽ ദി പാരന്റ്സ് ആൻഡ് ഗിവ് ദ പ്രൊഫൈലാക്സിസ് അഗെയിൻ. രാകേഷ്,
അത് തന്നെയാണ് സാർ പറയാനുള്ളത്. നമുക്ക് എഗെയിൻ നമ്മൾ അവിടെ പറയുന്ന ഒരു റീസൺ ലൈക്ക് മെനി ഓഫ് ദീസ് TB പ്രിവെന്റീവ് തെറാപ്പി റെജിമെന്റ്സിന് 1 year 2 year വരെയുള്ള പ്രൊട്ടക്ഷൻ കൊടുക്കുന്നുണ്ട് എന്ന് പല സ്റ്റഡീസും പറയുന്നുണ്ടെങ്കിലും as of now there is no global consensus on how frequently we need to repeat. But the common sense really tells us if the child is re-exposed with a definite exposure history, in such a child like who has a very close contact with an open case of pulmonary TB, that need to be considered as a reinfection, and we need to consider. That's what the common sense suggests.
Another question is, asymptomatic IGRA positive means infection or disease, whether that state is infectious. അപ്പൊ IGRA നമ്മൾ മാൻഡോ തന്നെ ആലോചിച്ചാൽ മതി അല്ലെ. മാൻഡോ is suggestive of a tuberculous infection which may be a past infection or a present infection or an active infection. ഏതുമാവാം. It is not a diagnostic test for tuberculosis. പക്ഷെ നമ്മളൊരു corroborative evidence ആയിട്ടാണ് അത് എടുത്തുകൊണ്ടിരുന്നത്. പക്ഷെ 2019 ഗൈഡ് ലൈനിൽ നമ്മൾ TB സിംറ്റം ആയിട്ട് വരുന്ന ഒരു കുട്ടി ഫസ്റ്റ് എക്സ്റേയും മാൻഡോയും ചെയ്യാനായിരുന്നു പറഞ്ഞിരുന്നത്. പക്ഷെ ഇപ്പൊ അത് മാറി. 2020 ഗൈഡ് ലൈനിപ്പോ എക്സ്റേ മാത്രമേ പറഞ്ഞിട്ടുള്ളൂ. എക്സ്റേ എടുക്കുന്നു, എക്സ്റേ ഹൈലി സജസ്റ്റീവ് ആണെങ്കിൽ നമ്മൾ മറ്റേ റാപ്പിഡ് ഡയഗ്നോസ്റ്റിക് ടെസ്റ്റിന് അയക്കുന്നു. എക്സ്റേ നോൺ സ്പെസിഫിക് ഷാഡോ ആണെങ്കിൽ കോഴ്സിന് ആന്റിബയോട്ടിക് കൊടുക്കുന്നു, എക്സ്റേ റിപ്പീറ്റ് ചെയ്യുന്നു, ഷാഡോസ് പെർസിസ്റ്റ് ചെയ്യുന്നുണ്ടെങ്കിൽ നമ്മൾ റാപ്പിഡ് ഡയഗ്നോസ്റ്റിക് ടെസ്റ്റ് അയക്കുന്നു. അപ്പൊ അതുകൊണ്ട് ഇതൊരു ഡയഗ്നോസ്റ്റിക് ഇൻവെസ്റ്റിഗേഷൻ അല്ല. ഇഗ്ര പോസിറ്റിവിറ്റി മീൻസ് ദർ ഇസ് എൻ എക്സ്പോഷർ ടു ദി ട്യൂബർക്കുലസ് ആന്റിജൻ. അത്ര മാത്രമേ ഉള്ളൂ. നമ്മള് പണ്ടേ പറയും അല്ലെ, അഡൽട്ട് ടി ബി മൾട്ടി ബാസിലറി ആണ്, പീഡിയാട്രിക് ടി ബി പോസി ബാസിലറി ആണ്. ശരിക്കും ലേറ്റന്റ് ഇൻഫെക്ഷൻ പോസി ബാസിലറിനേക്കാളും രാകേഷ് ഉപയോഗിക്കുന്ന ഒരു ടേം ഉണ്ട്, ഇറ്റ് ഇസ് ഓൺലി എ ഡോർമെന്റ് ഇൻഫെക്ഷൻ. കുറച്ച് ബാക്ടീരിയ അവിടെ ഉണ്ടാകും. അപ്പോൾ യൂഷ്വലി ഇറ്റ് ഇസ് നോട്ട് എൻ ഇൻഫെക്ഷ്യസ് ഡിസീസ്. രാകേഷ്, എനിത്തിങ് ടു ആഡ്?
അത് തന്നെയാണ് സർ പറയാനുള്ളത്. ഇഗ്ര പോസിറ്റീവ് അല്ലെങ്കിൽ മാൻഡോ പോസിറ്റീവ് simply tells us that there is an infection. It could be positive in disease also. അതാണ് നമുക്ക് പറയാനുള്ള ഒരു കാര്യം. അതുകൊണ്ട് റൂളിംഗ് ഔട്ട് ആക്റ്റീവ് ഡിസീസ് ഈസ് ആൻ എൻറ്റയർലി ഡിഫറെന്റ് സ്പെക്ട്രം. ലൈക്ക് ആസ് Rajit sir has said, chest X-ray, gene expert or CBNAT, whatever facilities are available, that's an active disease. IGRA or MANTO simply tells us that there is a TB infection. That's all. It doesn't mean that there is an active disease at all. But at the same time, we need to see whether there is an active disease using other modalities.
One last question in the chat box is, district committee formula adinte numbers. Our IAP President Dr. Narayanan will communicate the state TB cell with all pediatricians from government sector as well as the private sector to be included in that committee, and hopefully that committee will come to existence by the 3rd week of this month, which will be communicated in our all groups. Another is management guideline for childhood TB has been revised several times in past decades. The main difference in the new guideline is in diagnosis of latent TB with the introduction of sophisticated, perhaps expensive and unfamiliar test IGRA instead of the time-tested, cheap and reliable tuberculin test. It remains to be seen whether new test is going to make a big difference in preventing latent TB developing into TB disease. That was a exciting question. Ragesh.
Yes, sir, I will take this question. Till this date, till today, there was no protocol for treating latent TB infection in India. I repeat, there was no protocol for treating latent TB infection in India. We were giving TB preventive therapy to all under 5 children who are household contacts. Other than that, no guidelines or no protocol says treatment for latent TB infection. This is for the first time we are going to give. For TB treatment, yes, definitely yes. But in that also, we know about the limitations of MANTO. When we are going ahead with treating latent TB infection with a test like MANTO, the biggest problem is standardized MANTO are not available. Standardized MANTOs are not available. The cutoffs which we say are typically about the standardized MANTOs. Now, different laboratories in Kerala are using different strengths of MANTO. And on field investigation reports by a team of committee, including pediatricians, in some of the districts in Kerala, they have seen that the technique of MANTO is not at all standardized in Kerala. What we are following them, like reading, applying that, the dosage, the strength, everything is not at all standardized. And even the treating clinicians are not aware of such issues at all. So when we are here, we are trying to treat children who are having latent TB infection, but no active TB disease at all. So that means we are trying to treat healthy children who don't have any active TB disease at all. So in such a scenario, we cannot go with a test which is not sensitive or specific or not standardized. So only available option was IGRA. Yes, it's costly, but for children, yes, fine. Because to avoid unnecessary treatment, imagine children are receiving, all these are toxic drugs basically. We cannot give these drugs to children. Like we cannot overdiagnose or even underdiagnose. So that's what I would try to say. We need to have a standardized thing. We cannot make children take these drugs unnecessarily also. And The silver line is there is another test coming in, which is called CTB, the cutaneous TB test. So that is coming in shortly. The cutaneous TB test or the CTB test has all the advantages of Manto in the sense that it's very easily applicable. We can easily apply that. It's a skin test. Cost is very less. At the same time, it's very specific like IGRA. It is not affected by BCG at all. Due to COVID, that field testing has got delayed. So hopefully that will be tested in India very soon. And if everything goes right and if that is shown effective, we will be able to replace IGRA with CTB soon.
Ragesh, thank you. There is another interesting question. Is it better to underdiagnose or overdiagnose an active TB? അപ്പോൾ അത് രാകേഷ് പറഞ്ഞു അല്ലെ, അണ്ടർ ഡയഗ്നോസിന്റെ പ്രശ്നവുമില്ല, ഓവർ ഡയഗ്നോസിന്റെ പ്രശ്നവുമില്ല. നമ്മൾ ഈ ഒരു അൽഗോരിതം വെച്ച് പോയാൽ TB ആക്റ്റീവ് ഡിസീസ് ആണെങ്കിൽ സിംറ്റംസ് ഉണ്ടാകും. സിംറ്റംസ് ഉണ്ടെങ്കിൽ ആക്റ്റീവ് ഡിസീസ് എക്സ്ക്ലൂഡ് ചെയ്യാം. അപ്പൊ ആക്റ്റീവ് ഡിസീസിൽ മൈക്രോബയോളജിക്കലി കൺഫേംഡ് TBക്ക് നമ്മുടെ CBNAT പോസിറ്റിവിറ്റി വേണം. അത് ഇപ്പോൾ ഇമ്പോർട്ടന്റ് ആണ്. നമ്മൾ ഒരു മൈക്രോബയോളജിക്കൽ കൺഫർമേഷൻ കിട്ടണം. കാരണം നമ്മളിപ്പോൾ ഒരു ഡ്രഗ് സെൻസിറ്റിവിറ്റി ടെസ്റ്റിംഗ് എല്ലാ കേസിലും ചെയ്യാനാണ് പ്രോഗ്രാം ഉദ്ദേശിച്ചിരിക്കുന്നത്. In rare instance, you can make a clinical diagnosis if the child is having symptoms suggestive of TB disease, which is not explainable by any other condition. I think that is clear. We are going to conclude the session. It is very simple, even though Dr. Faisal narrated several eligibility criteria. The two common eligibility criteria are ഒരു വീട്ടിലെ പൾമണറി മൈക്രോബയോളജിക്കലി കൺഫേംഡ് TB ഉണ്ടാകുന്നു, അയാളുടെ 5 വയസ്സിന്റെ താഴെയുള്ള കുട്ടി നമ്മുടെ അടുത്തേക്ക് വരുമ്പോൾ നമ്മൾ സിംറ്റംസ് ഉണ്ടോ എന്ന് നോക്കുക. TBന്റെ സിംറ്റംസ് ഒന്നും ഇല്ലെങ്കിൽ we will put the child on the LTBA treatment. ഇനി 5 വയസ്സിന്റെയും 15 വയസ്സിന്റെയും ഇടയിലാണ് കുട്ടിയെങ്കിൽ സിംറ്റംസ് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ നമ്മൾ ആക്റ്റീവ് TB ഡിസീസ് എക്സ്ക്ലൂഡ് ചെയ്യുക. സിംറ്റംസ് ഒന്നും ഇല്ലെങ്കിൽ ഒരു IGRA ചെയ്യുക. IGRA പോസിറ്റീവ് ആയാൽ ഒരു എക്സ്റേ എടുക്കുക. എക്സ്റേയിൽ ഹൈലി സജസ്റ്റീവ് ഫീച്ചേഴ്സ് ഒന്നും ഇല്ല, നമ്മൾ ആ കുട്ടിയെയും പ്രൊഫൈലാക്സിൽ ഇടുക. ഇത് രണ്ടുമാണ് കോമൺ ഇൻഡിക്കേഷൻസ്. ബാക്കിയൊക്കെ HIV കുട്ടികളൊക്കെ നമ്മുടെ പ്രാക്ടീസിംഗ് പീഡിയാട്രിഷ്യൻ ലെവലിൽ വളരെ അപൂർവമായിട്ടേ വരും. നെഫ്രോട്ടിക് സിൻഡ്രോമും വളരെ അപൂർവമായിട്ടേ വരും. അങ്ങനെ എന്തുണ്ടെങ്കിലും the program gives a referral committee, that is the district level committee, discuss with them and decide. The one thing is very important, we have to adhere the RNTCP guidelines. We are legally bound to adhere that. Before calling Dr. Ragesh, actually Ragesh Mandra is this latent TB infection management. When I met him during the 2019 training at the Bombay, he was telling Kerala and IAP should take a leading role in treatment of the LTBA. No other states can do that. And Dr. Narayan also replied to that request in a very positive way, and we materialized our objectives of treating LTBA treatment. Thank you, Dr. Ragesh, and thank you, Dr. Narayanan, for making this program a success. And we will implement and follow up it in a strict manner. Before calling Dr. Ragesh, I just call my respected teacher, Dr. C.K. Sheshan sir, for a comment. C.K. sir, unmute yourself.
Okay. Thank you, Ashraf, for such a wonderful session. It started with Narayanan and ended up with Narayana Bhatt. And we are all very glad to hear that. And in fact, I could hear Dr. Ragesh, Dr. Madhura, and Dr. Sunil all speaking. Now, the point, just make few comments. I think the system is very good. We should start at the index level itself. Or index cases, if it is followed up, all the contact can be traced easily, just like what we traced in infection. That is first step, which I need not tell you or enlighten you. The second point I wanted to make is, we wanted to have an evidence-based treatment. So we are attempting to demonstrate AFB. My experience is really listening. See, we had a program on asthma. We wanted to, segregate the morphological types of asthma. We did the gastric aspirate. Always you got only gastric juice. We never got the respiratory sediments. So we induced sputum. I learned from former the late Dr. Vijayan, Institute Director, Patel Chess Institute, was sitting next to my room. So I learned from him how to induce Buddha. And then we collected, then we started identify morphologically at least 4 different types of asthma by looking at the cells. Where I learned, when we do the testing, we have a positive, AFB positive adolescent girls, only girls, not boys. This is the way we collected and we could prove it. So that is one way of looking at it. Then another point is, especially treating pediatricians, you must be treating so many patients with nephrotic syndrome. Beware, when we give ATT and steroid together, the same 450 is being stated. Yet the primary treatment of nephrotic syndrome gets deranged. They don't respond. We lost so many children in Calicut, and we took the help of the nephrologist. Then we had to discontinue treating them with the tuberculosis, anti-tuberculosis drugs, and maintain on steroid. Then what I want to tell was the treatment you said about reinfection. And again, we have a latent TB agreed, we are not treating, we are picking up, and according to the circumstances, we'll manage. But if that person is still the primary, not the primary, the index case is still spitting out the bacteria, what can happen to this child? This is a problem. This can happen. So the concentrating on the the index case is a primary thing that will settle all the issues that we discussed and found out. Regarding malnutrition, of course, as it was told by Faisal, it was absolutely correct, and I have no comment on that. No. Regarding FNAC, our experience with FNAC is really disappointing. We get a report, reactive lymphadenitis like that. So I quote Professor Balram Nair, our DME, our pathology professor. He said, if you want to do lymph node study, you take one lymph node as such. Excision biopsy, because you get the architecture of the lymph node and you get it. Now Ashraf is telling we are going for molecular studies. Even a bit of lymph node may be sufficient, but I am subjected to correction. I think there are the few things I wanted to mention in this situation. Anyway, now there is clear-cut information and clear-cut guidance. So there won't be any mistake as far as we think, as far as the treatment is concerned. But one point of thought: if a patient has to be referred who develop complications of that, I think the medical colleges should identify some of the medical colleges and let it be designated as a referral center. Because I saw a child coming from Paraparangadi. They sent it to Malappuram. From Malappuram, they sent it to TB center. The person is not available. That lady was in trouble. And they came to me. I sent directly to IMCH. You go there, they will admit you and do what is required. That was perfectly happened. So designate referral centers. And then the referral center, as Rakesh and Ashraf was telling, you have a committee. So they can act on a platform and decide what is it. That is one thing we have to know. Compliance is very, very important. So if a complication develops, ultimately the patient should not drop the treatment and designate specific treatment. A specific referral center has to be identified that will take care of all the issues. Dr. Narayan wishes can have a AFB-free air at least in care. Then everybody can take it from us.
Yeah.
Thank you, sir. Thank you. That's very, very, very practical suggestions. And one more important training program by Central IAP is pending. We have simply conducted due to the COVID situation, the training on our revised, updated guideline on pediatric TB treatment 2020. Hopefully, we will conduct it by January over this in every districts. Some of the districts it was over, but in Calicut, Malappuram, Wayanad, Kannur, and Kasaragod it is not over. We will do by 2021 January. And over to Dr. Narayan.
Yeah, thank you, Dr. Ashraf. First of all, thank you, Shashidharan sir, for your inputs. because I have noted down all the points, because the rich experiences of senior pediatricians, their practical wisdom has got many things to do with when you are forming a guidelines or protocol or something like that. Because it's all practical wisdom that is most important finally.
Yeah.
But and substantiated by scientific evidence. That should be our approach. So all the inputs should be considered when we are finally formulating. We'll be releasing a booklet, a tabletop reference for the treatment of, for the management guidelines of both latent TB as well as tuberculosis disease. So that will be available. Maybe Dr. Ashraf and Dr. Rakesh, they are in the they are preparing the book, and it will be released within maybe a couple of weeks. It will be ready. And as CK sir has suggested, the referral centers. Then the other point sir has pointed was the importance of collection of induced sputum. That already I think we have prepared a video how to collect induced sputum. So that we'll be giving training as a part of this program. There's a training program for nurses how to collect induced sputum. So that's a part of the program. So our when it is evidence based, as Sir has said, we must be able to isolate AFB wherever possible. That must be our goal. That will lead a long way in the control of tuberculosis. And all the other points, Sir, and all the what has been mentioned in the chat box, everything we'll be taking into consideration while drafting the final document. And I should thank Dr. Ashraf and Dr. Rakesh, because they have been in this team, in this workshop. In this week, we had 3 workshops. Each workshop lasting for nearly 2.5 hours. And they have been patiently attending each and every talk and each and every chat they have been attending to, and all the queries cleared, and in between giving short briefs about this thing. So it's not a single workshop. It is not a single training program. It has been 3 training programs addressing 800 delegates. So it's not a simple thing. So maybe it may be happening for the first time in the history of IAP Kerala, doing 3 training programs for 800 delegates in a week, in 3 weeks time, 3 days time. So real hats off to you, Ashraf and Rakesh, and all the speakers, because this time we have selected speakers who from different category. Maybe they may not be the very senior pediatricians, but they have been trained. They have been given a uniform PowerPoints and all, and they also did extremely well. And one problem we had was today being a day of holidays, both the Diabetic Day, then Diwali and everything. So the expected attendance from North Zone was not so, but definitely we'll be doing one more session, maybe next week after getting the free time of Ashraf and the speaker, Ashraf, Rakesh and speakers. We'll be definitely doing one more session. And at that time, all the pediatricians who could not attend their sessions in their zones, they'll also be able to attend. So by this, by next week, we'll be completing training of 1,000 pediatricians. Then we'll go with the district committee will be formed next week itself. Then the final booklet will be ready within maybe 2 or 3 weeks. So everything will be set for all the pediatricians of Kerala for a well-informed, scientifically proven TB protocol to do our practice. So Kerala will set a model for that, and this model will be emulated in other centers also. Along with that, we are planning to do some research studies, our experience. We have to record our experience, and we have to show the medical fraternity how it worked and what are the pitfalls or what are the positive points. That also we are planning along with this. For all these things, it's all with the support of the state TB cell and the WHO consultants and all. So Dr. Sunil was there here, he was addressing us. So all thanks to the the state TB cell and the WHO consultants. Thank you. Thank you all.
Thank you, Dr. Narayanan. As CK sir suggested, actually the state TB cell is providing a excellent infrastructure as well as network for the case detection, treatment, and follow-up of the children, whether the children or adults with the TB. And we will make use of it to make our program is an excellent one.
Right.
And I think Dr. Ragesh, in his concluding remarks, will address other issues raised by the CK. Sir, over to you, Dr. Ragesh.
Right, sir. So on conclusion, I just need to thank the entire senior pediatricians and Indian Academy of Pediatrics for recognizing that TB-free air is the right of every child. And since children cannot talk, as doctors of children, IAP is raising voice for children. So that's so wonderful initiative. And I need to thank all the senior pediatricians here. Only request is like what we, when coming to the children regarding TB, there are so many problems with the diagnosis. Only thing is now we have a program for latent TB infection management. Previously it was not there. We need to boldly diagnose whether it is TB or it is latent TB. Whatever the pediatrician says, the program will accept that, the diagnosis. But let's say that this is TB or this is latent TB infection. So we will differentiate between TB and latent TB infection now and treat accordingly. Like whatever is, for its TB, we need to treat for 6 months with 4 drugs, or latent TB, we can diagnose, treat it with 2 months. So let's be scientific so that children are not overdiagnosed or underdiagnosed. They are not getting unnecessary drugs, or they are not being denied any treatment. So this is for children that we are all doing this. And also IAP has promised to raise the voice to address the determinants like malnutrition. Again, malnutrition, as sir said, it's again a major determinant of TB in Kerala. Still, if we address the entire malnutrition in Kerala, we could reduce TB by 24%. Population attributable risk of TB is in Kerala still due to malnutrition is 24%. So we could bring out that. So with this, I think we also learned a lot from all the senior pediatricians and practical wisdoms from all the doctors here. We will be helping IAP in whatever extent, whatever way we could do that. So thank you so much again, all the senior doctors and pediatricians here for raising the voice for children. Thank you.
Thank you, Dr. Ragesh. Now the session will come to end. Lastly, I call Dr. Ajay V, the President-elect, Secretary-elect of IAP Kozhikode. Myself and Dr. Nihas is slowly slipping out of the President Secretary by this end of this month. And I request Dr. Ajay for a vote of thanks.
Thank you, sir. First of all, I would like to thank Dr. Narayanan sir for his leadership and for his inauguration of the program. And also, I would like to thank all our speakers, Dr. Faisal sir, Dr. Ranjit, Dr. Mridula, and Dr. Narayan Naik for their excellent sessions. They made the sessions look very simple, and the talks were very interesting also. Also, the sessions were well moderated by Dr. Ashraf and Dr. Ragesh, who are the main persons behind TB-free air. So thanks to both of you, sir. Also, I would like to thank Dr. Sunil Kumar, sir, our state TB officer, for his inputs. Finally, I would like to thank my colleague, Dr. Nihas, and all my seniors and the senior faculties for their excellent inputs. Thank you, everyone.
Ajay, meeting concluded. Thank you, Dr. Narayan, Dr. Ragesh, CK sir. Good night.
Good night.
Happy Diwali.
Happy Diwali.